PCOD is associated with hyperandrogenism and infertility. It's harbinger of a lifelong condition that can lead to the serious sequelae such as diabetes mellitus, hyperinsulinemia, hyperlipidemia, endometrial hyperplasia, carcinoma, central obesity, sleep apnea, etc. So we will review the pathophysiology of it. Taking the historical aspects, in 1721, the Wilsonary has gave the first histological description of PCO. Sclerotic changes has been described in 1844, and later on in 1935, Sten and Leventhal has taken the wedge resection biopsy in a 7 hirsute amenorrheic women, and they have demonstrated the histological picture of PCO, and since that time, this syndrome is started known as a Sten-Leventhal syndrome. In late 1960 and early 1970, dearrangement in hypothalamo-pituitary-ovarian axis has been recognized, and so the elevated LH upon FSH ratio has been established criteria to diagnose the PCO. The sonographic picture of PCO started recognized in 1980s, and after that in 1990, NIH criteria were established for the PCO, and later in 2003, during ISHRAE ASRM consensus, the definition of PCO has been properly established with the diagnostic criteria, what we know as a Rotterdam criteria of PCO. PCO is also known as PCOD, polycystic ovary, Sten syndrome, sclerotic ovarian disease, and many other names. Is not well understood. Lack of knowledge of location of primary defect has led to the difficulty in pinpointing the pathological site. There are several candidates involved in this pathophysiology. One is ovary, another is adrenal glands, third is a hypothalamo-pituitary-ovarian axis disturbance, and insulin-sensitive tissue, that is the peripheral tissue. So we'll take the one case. This is a case of 22-year female presented in the clinic with the female pattern hair loss, hirsutism, with complaint of acne and irregular delayed period since last 2 years. She was unmarried. On USG, bilateral ovaries were normal. None of the sonographic criteria of PCO was fulfilled in her case. But on investigation, her DHEA was 659, which was high. Prolactin was normal. Insulin was 14, which was normal, fasting insulin. But again, testosterone was 51.37. And her sugar was also normal. So this patient has clinical picture of hyperandrogenism. So this hyperandrogenism will lead to the increased conversion of testosterone to dihydrotestosterone, and this dihydrotestosterone will bind with the androgen receptors and will stimulate the terminal hair growth and lead to the hirsutism, as well as the growth phase of the hair, that is the anagen phase, has been reduced due to the dihydrotestosterone receptor binding, and it becomes 4 months instead of 6 months, and so the patient present with the alopecia and fecal matin hair loss. So understanding this, hyperandrogenism will lead to the increased aromatization in a peripheral tissue. It will also increase insulin sensitivity, insulin resistance, and hyperinsulinemia, which will lead to the obesity. And again, this obesity and increased androgen will lead to affect the hypothalamo-pituitary axis. And so the LH-FSH secretion will be get affected, and that will secondarily affect the ovary and will lead to the irregular periods and ovulative cycles. The another case, 29-year-old female with secondary infertility in last 4 years. She had a regular period 4 years back, but later since last 4 years, she had an irregular period of 45 to 60 days. She had first full-term normal delivery 6 years back without any medication, but at present she came for infertility. Missed abortion 4 years back. Her weight was, BMI was 26.9. That is high, showing the borderline obesity. And again on sonography, bilateral ovary was normal. sonographic picture of that same patient. On hormonal testing, she has a normal glucose fasting 92, but her fasting insulin was high, thyroid normal, FSH, LH, in that the LH upon FSH ratio was increased more than 1. Prolactin was little bit borderline high, but insulin was 25.5. That was high. That was showing the hyperinsulinemia. So in her case, the hyperinsulinemia was the problem for developing PCOD. Again, this hyperinsulinemia is not because of increased secretion of insulin which happens in diabetes, because her sugar is normal, and that is pinpointing her pathophysiology as insulin resistance, peripheral insulin resistance leading to the increased insulin compensatory hyperinsulinemia, and then this hyperinsulinemia will affect the liver, will lead to the decreased serum hormone binding globulin, so there is an increased free testosterone in the blood. On adrenal glands, it will provoke increased secretion of DHEA and androstenedione, that is the androgen of adrenal origin. Again, it will stimulate increased LH secretion, leading to the increased androgen from the theca cell of the ovary. And because of all these different organ involved, leading to the hyperinsulinemia, and that's why she has developed obesity, but going towards obesity, and presented with infertility and anovulatory cycles. Third most important reason we say is a genetic factor, or we say in utero problems. The one patient, she's 29-year-old female, primary infertility of 3 years, but having an irregular period of 60 to 90 days. She also had a family history of diabetes and obesity in sister and mother. So that was giving some hint towards that this pathophysiology means the reason may be genetic side. So her BMI is 42.9. So that is showing the morbidly obese patient. And on sonography, right ovary volume was 12 millimeter, left ovarian volume was 16. And both the ovaries were showing more than 20 antral follicle in both the ovaries, but no typical necklace petal. So we label it as a multicystic ovary with PCO features. This is her hormone report. Insulin, fasting insulin was showing 24.8. But with that, the sugar again is normal, 78. So she was not diabetic, but hyperinsulinemia. Serum cholesterol was normal, so she did not develop the hyperlipidemia. And prolactin was normal. And seeing all these things, this shows that the peripheral receptor defect, because her sugar is normal and insulin is high, that shows the peripheral receptors are defective, not responding to the insulin, and that's why the patient has developed infertility and amenorrhea. Again here, LH was less than FSH. So here, FSH-LH ratio was not altered. So hypothalamo-pituitary ovarian axis has not been disrupted. But all these things are related. AMH was 8.8. Many genetic factor has been found to be responsible for this. The most common genetic factor which have shown the association are CYP1, P450 and insulin receptor gene region. These have been shown the most common association with the polycystic ovary. The another studies have shown a high dopamine receptor present and TNF alpha receptors present in a Spanish population, and they have shown a very good association with the PCO. IGF2, this is also one of the receptors which is responsible for such type of association has been found with the PCO. So all these genetic factors, many genetic receptors are responsible peripherally, but they are not, like we cannot pinpoint a clear one genetic receptor is responsible for PCO. So it's all different correlation, but here in this her case, because she has a positive family history and sugar normal with high insulin, showing that probably she is genetically having some receptor deficiency in the peripheral tissue, and that's why leading to the such her clinical presentation. The LH receptors which are present in the ovary, if it's a defect here, then the ovary will start producing abnormal, means high androgens from the theca cell. Some deficiency of 17 alpha HCS receptors will increase the aromatization in the peripheral tissue, and again it will also lead to the hyperinsulinemia. The another size for the problem pathophysiology of PCO is hypothalamo-pituitary ovarian axis disturbance. This case is a 28-year lady presented with primary infertility of 10 years with regular menses, and her BMI is 17.8. That is shows the thin lean PCO. FSH 3.4, LH 9. So the ratio is almost 3 times. Thyroid normal but prolactin high. Sonography shows typical bilateral necklace pattern in both the ovaries with volume more than 10 cc. Her picture with AMH was 4.5. The another case of a thin lean PCO, she is 28-year-old having a first normal delivery and later on started developing irregular periods. BMI 19 with FSH 6, LH 13 and AMH 15.8. So all these portions are thin lean PCO where the hypothalamo-pituitary ovarian axis has been disturbed, these will lead to the rapid slow pulsatility of GnRH will lead to the increased LH secretion, but FSH secretion will remain less. Because of high LH, it will affect the ovary and there will be an increased androgen secretion from the theca cells. These androgen will again affect the peripheral tissue and will lead to the compensatory hyperinsulinemia. On other side, this peripheral tissue, because of raised androgen level in the blood, again it will promote the androgen production in the peripheral, especially adipose tissue. So it's a vice versa and vicious cycles keeps on going. And again, this hyperinsulinemia will affect the GnRH pulsatility, and again there will be a decreased FSH secretion and increased LH secretion. So in summarize, the increase in ovarian androgen production is the fundamental characteristic of pathophysiology of the PCO. And although the enigmata, it is at the heart of one of the major issues the hyperandrogenism. That is the main problem. Now, due to the increased hyperandrogenic environment of the ovary, it will lead to the small follicle in the ovary. And because of increased number of small follicles in the ovary, there will be increased secretion of AMH, anti-mullerian hormone from the ovary, from the follicles. And this decreased secretion of FSH is ineffective, which will not allow the selection of dominant follicle. And under the effect of AMH, increased production of AMH, it represses the effect of FSH on the antral follicle, and so dominant follicle selection will not take place, and so more and more number of follicle will start getting produced in the ovary, which will give the necklace pattern and multicystic ovary. And this AMH again will affect the FSH secretion as well as all FSH dependent aromatization activity also is affected by the AMH. So this is actually a vicious cycle which can lead to the different organ involvement. A woman can enter in any of this pathophysiology from any organ involvement, like maybe ovary may start with the affection of ovary, may start with the affection of adrenal glands, or maybe disturb hypothalamo-pituitary ovarian axis, but ultimately with the vicious cycle, all these characters will slowly get established in all these cases. The other factors which lead to the sometimes mimicking as PCO patients or sometimes indirectly producing polycystic ovarian disease are high AMH. Again, this AMH, whether AMH is responsible for PCO or PCO is responsible for producing anti-mullerian hormone is controversial. Many studies are saying that AMH is responsible for PCO. Other studies are saying that PCO will lead to the high AMH. Borderline hypothyroidism may have been observed in many patients because of PCO. It affects the hypothalamo-pituitary ovarian axis, and you can see the associated hypothyroidism and hyperprolactinemia in these patients. Same way, hyperprolactinemia, the borderline hyperprolactinemia may be seen with PCO, or sometimes borderline hyperprolactinemia hyperimmunogeninemia can lead to the anovulatory cycles and increase the androgen secretion and can again initiate the PCO circle. Then another is obesity, as I typically describe in the case 2, where a patient has a normal, full-term normal delivery first child and later on she has developed PCO and infertility was because of development of obesity, because her BMI has been increased from 17 to 26. Then diabetes and leading to the hyperinsulinemia, which also indirectly provoke the PCO pathophysiology of the polycystic ovarian disease and can lead to the all type of, then later on the patient will start developing Niagara and this hirsutism and all the features of hyperinsulinemia and hirsutism and all peripheral presentation may see. Then vitamin D deficiency. Recently, the literatures are saying that the vitamin D is responsible for the mainstay of the pathophysiology. Also, many the company has come up with the addition of vitamin D in medications, especially in hyperinsulinemia patients. And they says that the vitamin D deficiency is responsible for production of hyperinsulinemia, and hyperinsulinemia will lead to the presentation of PCO. The other theory says, I have just searched the studies and they have shown that the obesity and hyperinsulinemia is responsible for decreased absorption of vitamin D and decreased production of vitamin D. So probably obesity and hyperinsulinemia is responsible for the vitamin D deficiency. So again, this is a debatable reason for the PCO and vice versa. But concluding all this, we can say that the fundamental anomaly of PCO is still unknown, but it can be hypothesized that any genetic, epigenetic, or environmental factors can lead to the intra-ovarian hyperandrogenism can result in a PCO.
Yes, sir.
Thank you.
Thank you very much, Dr. Kokila. You have made very boring and difficult subject in an interesting. Thank you very much. Here I request Dr. Manjula Bhattiwala to hand over moment to Dr. Kokila in this side. I request our next speaker, Dr. Pooja Narkani Singh, and I request chairperson to introduce. It's my pleasure to introduce none other than our friend Dr. Pooja Narkani. She is a senior consultant IVF specialist and director at 21st Century Hospital and IVF Center since last 10 years. She passed her undergraduate and postgraduate from the DJ Medical College in Gujarat. She has undertook training of a diploma in endoscopy and IVF techniques from University of Kiel, Germany. She is practicing since last 10 years and already one of the youngest successful IVF specialists in the country. More than 5,000 babies from IVF. She is the first lady doctor from India. Now, her other characteristics. She is the first lady doctor from India to finish Forward's ultra marathon, a distance of 90 kilometers in South Africa. She also marathon and full marathon 42.2 kilometers and 18 half marathons and 2 ultra marathons and become the first lady from Surat to complete her Ironman. It says 2 kilometers swimming, 90 kilometers cycling, and 21.1 kilometers running. She is my marathon guru and she is passionate about her work and fitness. I welcome Dr. Pooja. As today's program is also not less than very marathon, I request all speakers to be precising time.
Thank you, Neela ma'am, for your kind words. First of all, I would like thank Indian Fertility Society and SOGS for giving me this opportunity. My topic here is ovulation, induction, and PCOS. So PCOS is one of the most common endocrinological disorder affecting 10% of the women. And as Dr. Kokilavan rightly told us that 2 out of 3 criteria, oligo-ovulation or anovulation, clinical or biochemical evidence of hyperandrogenism, and PCO on ultrasound. That is more than 12 small antral follicles in one ovary. Now this is the USG picture of PCO as we all see on in the clinical practice. Now these are the, in short, the causes of chronic anovulation: a relative FSH deficiency, hypersecretions of LH, insulin, estrogen, androgen, and inhibin B, attenuated apoptosis, aberrant expression of growth factors, and abnormalities in the ovarian stroma. That is, the theca cells hypersecrete androgens, granulosa cells have increased aromatase activity. Now, why is PCOS different? The main thing in induction is we should know that there is greater sensitivity to gonadotropin stimulation. So, therefore, multiple explosive follicular development. This happens because there is 6 times the density of preantral follicles compared with the normal ovary, and a large cohort of small follicle arrest in development but are capable of responding to exogenous FSH. So what happens is the androgens increase the number of preantral and small antral follicles before they are sensitive to gonadotropins. And androgens have a stimulatory role in early follicular growth by augmenting the follicular FSH receptor expression and therefore amplifying the FSH effects. So what are the multiple choices for ovulation induction in PCOS? The most important: weight loss, clomiphene citrate, letrozole, insulin lowering medications, low dose FSH, laparoscopic drilling, and IVF. So we're going to discuss some of these in detail. Weight loss. So obesity is present in 50% of the cases. Weight loss through diet and exercise has proven to be effective in resulting ovulation. Even 5 to 10% of weight loss makes a big difference, and patients, you see obese PCO patients coming to you with a positive pregnancy test. The important fact is reduce weight gradually, which increases the chance of maintaining that weight loss. Exercise increases the insulin sensitivity, and it should be the first line option for young overweight patients with PCOS. Now, what are the aim of ovarian stimulation protocols here? They should be simple, they should be cost effective, minimal side effects like OHSS, and best success rates. Now, in PCO patients, many are ovulatory as well. So, in these patients, there is an established ovulatory pattern, and multiple studies have shown improved pregnancy rate with ovarian stimulation as compared to non-stimulated natural cycle. The aim here is multiple follicular development. Now, this is the pre-induction checklist in which we do a day 2 FSH, antral follicle count or ultrasound, ovarian volume, AMH, and HSG and laparoscopy to assess the fallopian tubes. Regimens. Clomiphene citrate. It's the first line agent used over 40 years, 50 mg per day starting from day 2 to day 5. 25 mg to 250 mg can be used. And there is no difference in the pregnancy rate whether the clomiphene is commenced on day 2, day 3, day 4 or day 5. Although if we start the agent closer to periods, there is a tendency of multiple follicular development. Outcome: pregnancy rate is around 30%. Failure, that is no pregnancy in spite of ovulation, is 15 to 40%. Clomiphene resistance, that is no ovulation in 25% of the cases. And anti-estrogenic effect, that is 5%. Drawbacks of clomiphene: no pregnancies. There is a lot of controversy. No pregnancies occurred when the endometrium was less than 6 mm according to some studies, but few other studies by Kolibiansky have documented pregnancies even in endometrium less than 6 mm. There is an increased risk of twin pregnancy, 7 to 9%, and triplet pregnancies, hot flushes, visual blurring, and best to limit clomiphene citrate to 6 cycles. It increases the risk of borderline ovarian tumors. So now letrozole. It was banned for a few years and again it's come again with a bang. So excellent results in clomiphene resistant cases, clomiphene citrate failures associated with increased thicker endometrium and increased stromal blood flow, thereby providing the uterine environment which is more favorable. And letrozole has been shown to have higher pregnancy rates. Dose is 2.5 mg per day starting from day 3 to day 7, maximum 7.5 mg per day. And compared with clomiphene citrate, there is a high rate of monofollicular development, no direct anti-estrogenic adverse effect on the endometrium. It has a shorter half-life and lower serum estradiol. Now, this is a new extended letrozole therapy. In a recent study conducted, we give letrozole 2.5 milligram daily from day 1 to day 10. Used for clomiphene resistant PCO women. Higher number of patients ovulated, number of dominant follicles were more, and pregnancy rates were significantly greater with no extra cost. There's one more letrozole step-up protocol. In this protocol, letrozole was administered in a step-up dose of 1, 2, and 3 and 4 tablets of letrozole daily on day 2, 3, 4, and 5. And people have shown multifollicular development and pregnancies. Now let's go on to gonadotropins. Second line therapy for anovulatory polycystic ovaries. It requires ultrasound and laboratory monitoring. High cost, risk of multiple pregnancies and OHSS are the drawbacks. Now we have a lot of regimens. We are discussing these regimens mostly for natural planning and IUI cycles. IVF we would not be going into detail. So conventional regime, low dose step-up regime, step-down regime, sequential low-dose protocol, pulsatile GnRH and GnRH agonists. So this conventional regime has been in practice since 1970s, where clomiphene resistant all CC failure cases started from day 2, day 3, 75 to 150 per day, increased every 3 to 5 days by 50%. But there is high risk of OHSS 1.5 to 14%, which is unacceptable. The low dose step-up regime. This is the most common regime which we use in PCOS nowadays. FSH, there's something called FSH threshold. The follicle is rescued only when FSH goes above the threshold level. So if you gradually increase the FSH, it rescues new follicles. So we start from 75 IU per day for 14 days with 37.5 IU increase per week. And there is a 0 to 0.5% chance of OHSS. Lesser multiple pregnancies, that is 6 to 18%, and increased pregnancy rates 11 to 17%. Two studies compared the conventional regime and the low dose step-up regime, and low dose is the preferred protocol. Now the step-down regimen, increasing the starting dose of FSH mimics the mid-cycle FSH surge. So in this regime, they started with 150 to 225 IU starting dose and decreased by 30% every 3 days till the leading follicle reached 14 mm, up to HCG. Now type of gonadotropins we all know: HMG, urinary FSH, highly purified FSH and recombinant FSH. Cochrane database reviewed the type of gonadotropins. There were 4 RCTs and there was no difference between the ovulation rate, miscarriage rate, pregnancy rate and OHSS risk. So any can be used, but we prefer to use recombinant FSH at our center, of course with monetary considerations. GnRH agonists in IUI. GnRH agonists can be used to downregulate, but there is no significant increase in pregnancy rates in IUI and increased incidence of OHSS. Not be used in routine IUI and natural planning cycles in PCOS. Clomiphene citrate with gonadotropins. Now sequential use of clomiphene with FSH or HMG. Clomiphene 100 mg is started from day 2 to day 8. FSH or HMG 75 150 day 6, 7, 8. And transvaginal sonography from day 8 onwards. Additional FSH and HMG can be given till the leading follicle is mature. Also with gonadotropins, it's a good alternative to clomiphene with unexplained infertility undergoing gonadotropin stimulation cycles combined with IUI. In a prospective study by Miltavi and Casper, it was shown that aromatase inhibition with letrozole reduces the dosage of FSH required without any undesirable anti-estrogenic effects. GnRH antagonists. They act by the competitive inhibition of the receptors, which results in rapid decline in the FSH-LH levels, thus preventing the premature LH surge. It can be given in a single dose or daily dose regimen. Antagonist protocol, this is the common protocol, and gonadotropins are started as usual. An antagonist is started when the follicle reaches a size of 14 mm or from the day 6 of stimulation onwards in a dose of 0.25 mg per day till the day of HCG. The French protocol, gonadotropins are started as usual and a single dose 3 mg of antagonist is given when the serum E2 level is about 150 to 200 picogram per ml and the follicular size is 14 mm. However, there are studies which show that no significant differences in the pregnancy rates when antagonist was used. But at our center, we routinely use antagonists in IUI, although we use just 2 or 3 in the cycle. Now, overcoming the problems of ovulation induction in PCOS in IVF cycles, we usually go for mild stimulation, oral contraceptive pill pre-treatment, antagonist protocols, GnRH agonist to trigger ovulation, metformin, freeze embryos, and in vitro maturation. GnRH antagonist in IVF. The treatment is shorter and simpler treatment compared to the long protocol. It reduces the risk of OHSS, shorter duration and cost effective, and there are similar pregnancy rates. There are a lot of studies comparing GnRH agonists and antagonists in ART cycles in patients with a high risk of OHSS. And GnRH agonists are the drug of choice here. So this is a study in which 87 patients were on agonist protocol. And there was a high risk of OHSS. There was 56% cancellation rate and around 27% moderate to severe OHSS. Compared to that, the GnRH antagonist protocol is much safer and the results are comparable. Now, this is a study in which GnRH agonist versus HCG was given in high-risk IVF patients for trigger. The trigger was compared in the antagonist cycle with the GnRH agonist trigger and agonist cycle with the HCG trigger. OHSS was 0% versus 31%. Ongoing pregnancy rates were 53 versus 48%. That's almost the same. However, adequate E2 and progesterone supplementation should be given in the luteal phase, wherein the GnRH agonist is used for trigger in IVF. Now, insulin sensitizing agent. Metformin, metformin is the most widely studied agent used in PCOS. It acts by inhibiting the hepatic glucose production and increasing the hepatic peripheral uptake, glucose uptake. The meta-analysis concluded that metformin alone can also achieve ovulation in PCOS, along with weight loss. So clomiphene citrate plus metformin compared to clomiphene alone, both ovulation and pregnancy rates were statistically increased in certain studies. Metformin has a role in clomiphene-resistant cases, 250 mg to 500 mg per day to 850 mg PDS with food. Nausea, bloating, cramps and diarrhea are the side effects. This is a study in which metformin was also used for IVF, in which 73 polycystic ovarian patients were taken for ICSI and compared with metformin 2 grams per day with placebo. There was no difference in stimulation IVF or clinical criteria, but in the group with BMI less than 28, pregnancy rate doubled on metformin. But there are controversial studies which say that metformin does not have a role. Another drug is myoinositol. It's a molecule which has promise in improving the hormonal and metabolic parameters in PCOS. A review of 12 RCTs showed that myoinositol improves oocyte quality and can also restore spontaneous ovulation in PCOS. Ovarian drilling induces ovulation by reducing the ovarian theca and ovarian androgen production. Cochrane review published in 2007 showed 80 out of almost 80% patients of PCOS became ovulatory after laparoscopic ovarian drilling. Fewer multiple pregnancies decreases the risk of OHSS and may be considered in clomiphene citrate resistance cases. Drilling can also be used in severe PCOS who cannot go for IVF because of monetary or religious reasons. Now, the most important thing of ovulation induction in PCOS is the prevention of OHSS. The incidence is higher, 15% in PCO patients than normal, which is 3%. So we'll shortly go into the prevention part, in which we predict OHSS from the history, examination and ultrasound. Laparoscopic ovarian drilling in PCO has a role. Metformin in PCOS can be given to reduce OHSS. Low-dose gonadotropins, gonadotropin antagonist protocols, GnRH agonist to trigger ovulation, in vitro maturation of oocytes and replacement of only one embryo. Secondary prevention, withholding HCG and continuation of GnRH agonist or antagonist, posting or delaying HCG, use of agonist to trigger ovulation, follicular aspiration, cryopreservation and replacement of all frozen embryos in the next cycle, progesterone for the luteal phase, dopamine agonist, albumin, glucocorticoids and aromatase inhibitors. So friends, to summarize, patients with PCOS commonly present with history of infertility due to anovulation. So first line of management includes weight loss, diet and exercise. Clomiphene citrate has been widely used as the first line of medication safely. Insulin sensitizing agent as a second line, especially in older patients who have increased visceral obesity. Laparoscopic ovarian drilling in clomiphene-resistant cases, all in older patients who cannot afford IVF, they can still wait and maybe get a natural pregnancy with weight loss and drilling. Low-dose step-up protocol with recombinant FSH and IUI, and timely referral to a fertility clinic for IVF with the use of gonadotropins with antagonists. Thank you everybody for your patient hearing.
Thank you, Pooja, for a very elaborate and simplified management of male PCO only. Thank you. Now I request Dr. Ruta Gogani to hand over moment to Dr. Pooja Nakari.
Friends, those who have not signed and they are inside the hall, I would request them to please sign the register because they are handing over to the observer and Dr. Parliament. Please sign.
Now I request Dr. Bharati Devanara to honor Dr. Muthu's name. I request Dr. Usha Gadra. Now I welcome our chairperson for second session. We welcome our GNC observer, Dr. Parul Verma, madam. I request Dr. Rajesh Kiri sir to present moment to Dr. Parul Verma. Now we welcome our next chairperson of second session. He is ex-professor Government Medical College. He is SOGS past president and present president of Private Advisor Dr. Sir. Please Here I also welcome Dr. Chintan Thakkar. He is the director of Mothercare Hospital College. So please take it.
रैपिड फायर क्या होगा?
Now I request chairperson to introduce our next speaker.
मेरे से लगा है वो एक्स्ट्रा जो डिलीट कर दो ना
On behalf of Surat OHSS Society and Indian Pathophysiology Society, Gujarat chapter. First, let me congratulate our President Dr. Jayesh Patel sir, Secretary Dr. Jayesh and Joint Secretary Nimish for all who organized such a wonderful symposium. I welcome you all. Second session, first Dr. Mamta
वाइफाई से कनेक्ट कैसा है?
Good morning, dear friends, and welcome on this wonderful morning for this wonderful academic session. Our first speaker on this second session is Dr. Mamta Dindal. Her academic qualification is MBBS, PCO, and MD. We have always heard that females are very fond of gold, but it seems Madam is fond of gold medals. In her academic awards, she has received a gold medal in MBBS. To continue her journey with gold medals, she received economics, University gold medal in pathology, Shiva gold medal in ophthalmology, University gold medal for final MBBS obstetrics in gynecology, gold medal for best performance in University anti-obstetrics and gynecology. Her professional career was she was assistant professor in obstetrics and gynecology of Osmania Medical College from 1983 to 1988. Training in reproductive medicine. Undergoing specialized training in infertility with with Professor H.W. Mitchellman and Professor Ediber in Germany. Her awards and honors, there's a long list. She got a Mahila Gaurav Puraskar in October 1997. Rashtriya Ekta Award in November 1997. Sir C.V. Raman Professional Expertise Award in March 1999. The list is very long. So we'll just quickly go through her field of activity. She is an established independent infertility institute and research center in 92. The center handles about 10,000 patients annually. She is completely equipped with diagnosis and treatment center, performs IVF, ICSI, video enhanced laparoscopic surgeries. There are around 500 IVF cycles annually and 600 advanced laparoscopic and hysteroscopic surgeries. Since we are already running late with our session, please excuse me for short. Making this introduction short, I would request Madam to continue and go ahead with her lecture. Thank you.
Thank you very much for that introduction. I never used to make things about myself. A very good morning to all of you, and I do hope I can keep my time, but if there is one message that I can get to all my colleagues sitting in this audience on a Sunday morning, that message is do ultrasound yourself. And if I get this message across to you, I've done my job coming to Surat. Thank you, Dr. Jayesh. It was very nice of you to have called me, and it's always a pleasure to be here. Today, I'm going to speak to you about a syndrome, a complex manifestation. A manifestation that happens in 1 in 5 women, it's that common. It is a heterogeneous condition affecting women in the reproductive age beginning from puberty to menopause, and particularly in reproductive age. It is relevant because it affects the family members, and metabolic conditions are known in the first degree relatives as well. This is a syndrome which involves many disciplines, beginning from a metabolic syndrome where all the doctors have a hand in it, including the cardiologist, the dermatologist, the fertility specialist, and not to forget the psychiatrist. In other words, there are clinical implications across all the lifespan, and all it takes is to do one good ultrasound and give the diagnosis. That's it. There are 2 lessons that I learned, and I think it is extremely important that I mention this to you. It's always nice to know that a person is experienced. Basically, he made mistakes and doesn't have mistakes to be learned again. That's what he's experienced. This was in the year 1990 when I started practice. I had just returned to Germany, and I used sonatropins on this 39-year-old woman. You can see that she has a scar on her abdomen there. She's had a resection in the past. I was so excited when I started her on 150 HMG alternate day, which was the protocol I learned in Germany, and I started to monitor her. The mistake was I never did my ultrasound myself, and I gave her head CT 10,000, I did an IUI for her, and 21st day she lands up in my clinic and collapses at the door. I didn't know what I wanted to do for her because I just heard of hyperstimulation, I'd never seen one, and when I went ahead and looked at her, her BP was not recordable. I shifted her into the hospital, which was the best thing to do. I thought I should lie down in the bed next to her. And she went into renal failure, ARDS, pulmonary embolism. Of course, I have the guts to put her picture up because she survived it. She had a treatment, but she was a lesson that I learned because I felt responsible. So never take a PCO for granted. The The second lesson I learned in the last 10 years, when I saw these young women who are just 20 between, these are probably in the last 2 years, I saw 5 patients like this, all young women. This was a 24-year-old doctor who came to me for treatment, and she had failed, I think, 3 or 4 cycles of IUI with clomiphene, and I wanted to induce ovulation, so I did her scan. She had typical polycystic ovaries. I looked at her ultrasound, and all I found on the baseline scan was there was loss of junctional zone here. That's it, nothing else, and a thick endometrium. I put my Doppler signals and I saw blood flowing into the endometrium, which was very suspicious. A hysteroscopy revealed that I was dealing with malignancy. This was undifferentiated adenoma of the uterus. So never ever exclude evaluating the endometrium PCOS. She had a hysterectomy, that's another story, at the age of 24. I have seen 4 more cases of this nature in the last 2 years. So you can understand how common it is in these patients. Having said this, let me go back into something which I always believed. Once upon a time, this is what the ovaries of PCO meant. An obese woman, pigeon-sized ovaries, Steen and Lilienthal, and what they described as a hyperandrogenic syndrome, subsequently polycystic. So they needed a laparotomy and examination to make the diagnosis. Then came in the conference, the first international conference, the NIH, first in 1990 and then 99. They concentrated on hyperandrogenism and menstrual disturbance. Polycystic, though the name was polycystic, they did not bother about ultrasound features. It was not important. By the 2003 Rotterdam criteria, where ultrasound became an important part, and the magic number was 12. So you had 12 antral follicles in the baseline scan with a volume of 10 to call it polycystic. Of course, this is now, the Rotterdam criteria is getting revised, and the magic number is 19. And probably this is because of improved resolution. But if you look at the Rotterdam criteria, this was based on only one single paper. Having understood this, then came in 2006 the Androgen Excess Society. They said that polycystic was an androgenic disorder and PCOS by ultrasound may or may not be necessary. Having understood this, then came the task force reports, and today, because of improved resolution, not because the number of follicles have improved, but because of improved resolution, the present criteria is AFC of 25, the volume remains the same. Having understood this, when I Googled ultrasound and PCOS, you can see what I saw. The number of results that I got was 5,50,000. This is an enigmatic disease, and the number of data that come out is enormous. So today, Dr. Jayesh asked me to speak on the clinical application of ultrasound. Just a little word here. The pictures in this presentation are entirely what I have taken on my machine. None of them are copied, which means we all sitting here can get the same pictures. This is another one of them. And if you see pictures of this nature, you suddenly believe that your laparoscopic surgeon doesn't need much more to tell you except to take this action. Having understood this, there are 4 questions that we need to answer. Now just a minute, how many minutes do I have now? 20 minutes more? There are 4 questions that need to be answered. This is a very practical presentation because I felt that if I was a person who was listening to a lecture, I should have a take-back message with me. So there are 4 important questions that we need to ask ourselves. Is it a PCO? PCOS the same? What are the diagnostic parameters of PCO? What is the clinical significance of each of the parameters? And how does one translate these findings for management options? So having understood these 4 questions, I go ahead. The first, polycystic ovaries is not synonymous with polycystic ovarian syndrome. It's not. Polycystic ovary is only a morphological appearance of the ovary, a numerical reference to the volume and a numerical reference to the number of antral follicles within the ovary. What does this mean? What is this numbers for? If the polycystic morphology is seen, it implies histologically and endocrinologically there is disordered folliculogenesis. The first speaker spoke quite extensively about this. What is the disordered folliculogenesis? There is an increased density of small preantral follicles, 2 to 5 millimeters. There is arrested growth of the larger follicles. There is obviously hyperandrogenemia, hyperinsulinemia, and even if you see a polycystic who's ovulating, usually she has mild insulin resistance, which is also associated with miscarriage and subfertility. The endocrine abnormalities, again, just for the purpose of this lecture, if she is anovulatory, she has an excess of the testosterone, LH, and insulin. The ovulatory PCOS, on the other hand, have lesser insulin resistance and more of androgen levels. So this is polycystic morphological appearance. Now, if you look at the syndrome comprises clinical, which you all know, ultrasound, which is a typical feature that I'm going to talk about, and also biochemical, that is high androgens, high insulin, and insulin resistance, high age. We all know this, there's nothing surprising about it. We must understand 26% of the women with amenorrhea, 87% of the women with oligomenorrhea, and 90% of the women with hirsutism will have polycystic appearing ovaries on ultrasound. There is something called an isolated PCOS. An asymptomatic woman with a PCO morphology, 32% of the women have this. If these women are subjected to treatment and ovulation induction, they behave like a PCOS. They have a higher incidence of hyperstimulation compared to the controls. The second question that needs to be answered is, what are the diagnostic parameters? We know that ultrasound has a definite role in the diagnosis. Are you all with me? Are you all with me? Yes. Okay, great. There is a role of ultrasound in PCOS, but what are the criteria? So let's look at them. But before we look at the criteria, we have to understand there are some technical recommendations. Number 1, it should be performed by a trained person. Number 2, transvaginal approach is the correct way. If she is menstruating, it should be done in day 2. If she's oligoamenorrheic, then it should be after 3 to 5 days of progesterone withdrawal. And if she's amenorrheic at any time. The ultrasound criteria are the 2D ultrasound, the 3D ultrasound, this is called the solo ABC and the inversion mode. I talk about it. The ovarian volume estimation, the vascularity evaluation, and the stromal ecogenic. I'll discuss this one after the other, explaining the clinical significance. Should we do a 2D or should we do a 3D? A 2D will definitely have limitations, but most of the time, it's all that we need. As long as you're not distracted by a pretty nurse next to you, if you're a male, or if you're not distracted by your wife's call as well. With the advent of 3D, life becomes easier. You have a more global assessment, a spatial orientation, highly reproducible, standardized, and you get reliable information. We know that PCO morphology is only 2 things: the antral follicle count and the volume. Antral follicle count of more than 12, volume of more than 10. Simple, doesn't require too much. And considering this is a financial city, I suppose these two numbers are pretty easy for you. But there is no rule, according to the consensus statement, for peripheral distribution of follicles, for blood flow, for stromal volume, and echogeneity. And believe me, my dear friends, maybe it is not really the correct way. Sometimes we see that the ovary, only one ovary is polycystic, the other is absolutely normal. This can happen, it has been described. But peculiarly, the polycystic ovary shows all the features of polycystic and the normal shows no features. And what this is, I'll talk to you in a minute. The next question is, what is the clinical significance? Suppose I have high antral follicle, what's the clinical significance? Suppose I have a high volume, what is it? So let's go, because Jayesh told me that I have to talk about clinical significance. So the diagnostic criteria, the most important diagnostic criteria is more than 12 follicles. So having understood this, the first question, why should you have more antral follicles? We know that there is more androgens. Like the first speaker already told us, when there are more androgens, there is going to be follicular recruitment from pre-antral to antral. Are you with me? The next thing, the high androgen levels, the high follicular recruitment and hyperandrogenism, there is excess development of follicles between 2 and 5. They go on till 9 millimeters and then get arrested because it is counterproductive. So when you see high antral follicles, you know the androgen levels are high, there's recruitment from pre-antral to antral, and she is having responsive follicles, unnecessarily called as cysts. Then the next question, why is it that you have to count these follicles? What is the need? Because we know we have to make a diagnosis of polycystic. And why should we make a diagnosis of polycystic? Because they have so many metabolic problems. You need to address the metabolic problems. It's not counting the number of follicles, it is addressing our metabolic issues and the stimulation issues. So that is why you need to count the number of follicles. The next thing, I look at a polycystic pattern recognition. I know immediately, look at this, I know it's polycystic. I reconstruct, I know it's polycystic. I do a solo ABC, I know it's polycystic. But how do you do this? As a matter of fact, this little cartoon here actually is saying that the doctor was so fed up and counting the follicles that he went out of the window. So, when should it be done? Early follicular phase, but can be done at any time of the cycle because intercycle variation is very low. You should not do an antral follicle count if the patient has had co-sequence. You must do a transvaginal ultrasound using a high frequency probe and count from one end to the other. Which are the follicles to be counted? They are the follicles between 2 and 5 ideally, between 2 and 9 definitely, and not more than 10 millimeters. Because more than 10, those are the atretic follicles. The 2D assessment, again, you have to go and concentrate on your machine and follow it from end to end. On the other hand, how does antral follicle by 3D help? Because then technology helps you to identify this and then report is given. Now, there is something called a bridge system, which is further to count these follicles. The next important point. There are two types of follicle distribution. One is called the general cystic pattern, where you see follicles all around the ovary. And the other is called the peripheral cystic pattern, which is follicles on the periphery like string of pearls. This is significance. If I see string of pearls, what does it mean? If I see multicystic, what does it mean? We know that polycystic morphology is an evolution process. Atretic follicles from the center go and get pushed to the periphery by the increasing stroma. So patients who are severe polycystic have actually the peripheral pattern, and the early responsive polycystic has the multicystic pattern. This is very important when you are stimulating them. For example, you stimulate these patients, you require higher gonadotropins. You stimulate these patients, you require lower gonadotropins. So, Jayesh, I'm trying to correlate as much as possible. The next is the ovarian volume. When you're looking at ovarian volume, a volume of more than 10 is what is looked at. There are methods of calculating both by 2D and 3D, and since it's not an ultrasound lecture in terms of how to do it, I'm not going into details. The next is stromal echogenicity. It is not included in the criteria, but when we look at stromal echogenicity, I sort of tend to concentrate on that because we know that increased stroma means increased androgens. Increased androgen means more resistance. So what I do is subjectively on 2D classify it as 0, 1, and 2. If it is markedly increased, then she definitely needs to reduce her androgens before stimulation. There are many 3D assessments, what is called the ovarian stromal area by total stromal volume area. If it is more than 0.32, it's a sign of hyperandrogenism, and so is it with volume ratio. These, of course, are some things that are done, but it is not mandatory, so I won't go on it. But what is the correlation? If you see increased stroma, you know she's resistant, you know she's insulin resistant, you know she's hyperandrogenic. Just looking at it. Looking at the Doppler, when you look at the Doppler, this is no role. Do I still have time? Yes. Okay. So, when we're looking at the blood vessels, it's very important, though it is not a part of the consensus. Which is the blood flow you look at? You're applying the blood flow to the ovarian vessels and the uterine vessels, and what did you notice? Between day 8 and day 10 in a normal ovary, you don't see increased vascularity. But in a polycystic, you see increased vascularity. And when you see increased vascularity, these are the dangerous ones. They hyperrespond. When you look at the uterus, on the other hand, there's increased resistance. So the vascularity is more in the ovary and more resistance in the uterine vessels. That's the point. Of course, Doppler analysis by 3D, the BFI, the BIFI are used. This is more on a research setting. Again, I won't be talking on things that are on a research setting because it doesn't help us practically. When you see a stromal PSV on the day, that is the peak systolic velocity from the stromal vessels in the center of the ovary on the day of stimulation, it is more than 10, go down on your stimulation. Otherwise, they will hyperrespond. So I use this for my stimulation protocols, and I'll tell you in a moment. Then why is it important to us? We know that increased LH, there is new vascularization. When there is new vascularization, there is total vascularization. When there is, particularly in the peripheral pattern patients, the general pattern patients, more follicles in the center, they are more responsive. It is higher in women who are hyperandrogenic, and these are the ones who actually hyperrespond. Whereas when you look at the uterine vascularity, mind you, these are pictures that I took on my machine, and they're really beautiful because you can really understand them. So they have a vasoconstrictive effect on the vessels of the uterus. This leads to inadequate perfusion, and this is why you have higher implantation failures and higher abortion rates in PCOS. The last question, how do you translate the reports that you have seen from the diagnosis for your treatment plan? When I am planning a treatment cycle, I use the AFC, the ovarian volume, and the vascularity. Which are the follicles I measure? All follicles more than 2 millimeters. Which are the follicles I concentrate on? Follicles between 2 and 5. Which are the follicles I exclude? Follicles more than 10 millimeters, because these are atretic follicles. I of course use the EMH as well, but we must understand follicles between 2 and 9 are counted by your Sono ABC, and hence you just take the total and calculate it. We use certain criteria I'll talk to you in a moment. So how do we plan my initial stimulation? I look at the ovarian volume, I look at the vascularity, I look at the antral follicle count and the stromal PSV. And then I use a nomogram this is the article by Popovic and Tadorovic, which I use on a regular basis, and I have been using this over the last 10 years. The next advantage of knowing your ultrasound is prediction of OHSS, the pre-stimulation. If you get a PCO pattern, if the number of follicles per ovary are more than 11, a volume more than 10, you must suspect hyperstimulation. During stimulation, if the total number of follicles that are getting recruited are more than 20, more of small and intermediate follicles, less of larger follicles, higher E2, you have a higher hyperstimulation rate. The third advantage is to use this to calculate who are the patients who will benefit from an ovarian diathermy. These are women who are thin, patients with an ovarian volume of more than 15, who have an antral follicle count per ovary more than 15, who have a tendency, particularly in the previous cycle, to go into OHSS, have increased stromal volume and a peripheral cystic pattern. These are the patients who actually benefit from your laparoscopic drilling. This is something which I want to give you as a take-home message. Can I just take 5 minutes now? Is it okay? Okay. In all our patients with polycystic, in addition to looking at her ovary, we go into her uterus. We do a sonohysterogram for all of them. For example, this was a patient on day 2 with a thick endometrium. When I did a sonohysterogram, I saw her cavity. She had 2 polyps, confirmed by the 3D. So you can see that these patients are polycystic in the baseline scan. If they have a thick endometrium, beware. These are the patients who must be biopsied to exclude malignancies. Here are some patients who I have seen in the last 1.5 months. A patient with a thick endometrium, vascularity, but the junctional zone was intact. A 3D showed again the junctional zone intact. The sonohysterogram was, the cavity was perfect, junctional zone fine, and this was an endometrial, simple endometrial hyperplasia without ATPI. This was another 22-year-old PCO. You can see the typical cystic pattern. Junctional zone is still intact, but high vascularity. This patient had ATPI hyperplasia. Again, in this case, we will see the junctional zone was getting distorted by excluding the cavity. When we looked at our vascularity, there is intense vascularity on the polycystic ovaries, and a biopsy indicated that she had this always women with PCOS have 2.7 for increase
एक मॉडिफाइड है जो एक मॉडिफाइड
if the patient uses OCS for the longer period.
एक पीसीओएस
There is a subgroup of PCOS who has increased risk of developing ovarian cancer. The incidence of developing breast cancer is not as much as described. There is insufficient data to link it with vaginal, vulvar, and cervical cancers. It must be remembered that patients who have metabolic syndrome need to be further evaluated, particularly if they have cardiovascular risk or the fitness, syphilis index, and definitely to look at the liver for a non-alcoholic fatty liver disease. When we are talking of polycystic ovaries in adults, please do not use a Rotterdam criteria for these patients. Normal development features of pregnancy.
Next is yours. Would you like
So
to
we
be direct
cannot
or
make
should I
diagnosis
shift
of
initial first
polycystic in
and then you are okay with
unless she is over.
so then make it your as per the schedule.
Yeah. It might take a message. Whatever may be your feature that you see on ultrasound, remember that ultrasound is important to assess the features of the ovary in all clinical presentations. Look at her other endocrine, biochemical, and metabolic tests as well. Don't just concentrate on the ovary and stimulation. Puzzle of the pathogenesis and the pathology, pathophysiology is solved. The treatment modalities will be more specific and successful in and not to manifestations of this really fascinating syndrome. Ultrasound is one of the marvelous imaging techniques, and it continues to amaze me and all of us. Thank you very much, ma'am. I would like to request Dr. Jayesh to comment.
Dr. Jayesh, sorry.
Continuing with our session, our next speaker is Dr. Leena Malhotra. She is a teacher, professor in the Department of PCOS. She did MBBS, MD, ED, job medical diploma. Issue achievements is Commonwealth Fellowship, Voice Chat Fellowship, OHSS on RCA. I welcome you, Madam Dr. Leena Malhotra, to continue with your talk.
उसमें से लिया ना,
वो भी लिया ना, आपने कहाँ रखा?
मैंने भी लिया मैं।
हाँ, बस।
इसको अप एंड डाउन यहीं से है ना? जी,
स्लाइड्स ऊपर
Yeah. A very good morning. Yeah, a very good morning to all the present here. At the outset, let me thank Dr. Jayesh, and the IFS Gujarat chapter to have me and Dr. Gauri here. I think this is I must say, the nick of the time we've made it. I think we've never made a kind of an entry like this. We've just come straight from the airport, but it's really kind of feeling very delighted to be here. Now, since it's a PCOS session, I know I missed the first 2-3 lectures. So if I kind of talk a little extra, please forgive me because there may be a little overlap. So I want to talk about troubleshooting infertility in PCOS. We know it's a common problem, and I think this is a snapshot of all the problem that I say. It's a heterogeneous disorder, and if I could say it's an ovarian expression of a metabolic syndrome. Something which the woman will develop later on will be diabetes, but in her reproductive years, she's presenting with infertility and menstrual problems, and that's PCOS. So just taking quickly from there, when we talk of problems in infertility and what will be troubleshooting, just a kind of recap, we know that there is disturbance at all the possible, hormone level, the peripheral fat, the adrenals, and these somewhere are culprits in causing her to have anovulation and infertility. Now, of course, this must have been talked by the previous lecture, we talked on the pathophysiology, but we know that there are abnormalities in the hypothalamic pituitary ovarian axis, and ovaries, of course, at the receiving end. Whatever said and done, it is the hyperandrogenism which is responsible for the negative feedback, and then the bottom line is a high LH. This is what we understand from whatever we have got from the molecular level studies. And needless to say that there is an abnormally high LH surge, an abnormal LH secretions, and this tonically elevated LH is responsible for the disturbed folliculogenesis, and of course, a lot of, milieu which goes disturbed at the level of the ovaries, which are leading to the problems of atresia and the like, which lead to infertility. Of course, insulin resistance is responsible and is acting synergistically with the LH. But the important thing is that even if we understand the molecular mechanisms, we are still naive as to what causes anovulation. And these are all the kind of factors that we look at, because we have to understand them when we know why she's troubleshooting, because the reason is if you understand troubleshooting, only then can you kind of treat them. So yes, is it all these? But I think lately we've tried to get more knowledge about a new marker of the anti-Mullerian hormone, which we think is responsible for the hyperresponse. Yes, but it's also responsible for the follicular arrest and atresia, because women who have high LH have also known to behave like poor responders when it comes to PCOS. We understand that the AMH is responsible for the follicular maturation, but once they mature and the dominant follicle is not selected, it is the FSH which is getting resisted by the AMH, i.e. to say that it's the AMH which is having a negative impact on the FSH receptors, and that is what is responsible. Of course, there is premature luteinization which happens in these women, and that's how all the play about of the whole pathophysiology. I again won't take you into the details of all these kind of molecular factors, but the end result is that there is no ovulation. Now, I know that we all are really worried in a PCOS about LH. So do we call LH a friend or a foe? Yes, it's a friend because it's needed for the follicular genesis, and there's a threshold to which the follicles need LH. But then once this gets abnormally high, as it happens in PCOS, it becomes an enemy and it's a foe. And that's what it causes: the downregulation of the receptors, follicular atresia, and premature luteinization. So if we understand, when we're doing a control ovarian hyperstimulation or a normal ovulatory cycle, when this threshold gets beyond the control or the ceiling goes too high, then that's what it calls a rest and a level which you defined as more than 5 milli-international units per ml. Now, of course, the ovulation induction part has been talked, and this is what we really go about when we do treatment. I would just kind of restrict myself to the troubleshooting in the first line, second line, and third line of management. That means troubleshooting when we are doing ovulation induction with clomiphene, troubleshooting when we're giving gonadotropins, and troubleshooting when one is doing IVF in PCOS. Now, of course, the first way when we're looking at is their anovulatory, and therefore we are kind of looking them. Are we looking to give them a monofollicular ovulation when she's just anovulatory, or I want an ovulatory PCOS to perhaps give me a little more than a single egg in an IUI cycle, or I want a cohort of follicles coming up as in a COH. So that's what is the basic understanding. But then whenever we are doing a COH also, we don't want too many eggs. Our kind of area where we are safe is something between 8 to 15. But that does truly happen in a PCOS is what we should understand. Now, of course, clomiphene would have been talked. I won't really talk about this product, but I just want to get you just to the result of the therapy that you give with clomiphene, and to understand what is troubleshooting in clomiphene is. Fantastic drug for a PCOS, gives excellent ovulatory rate, 70 to 80%. But look at the pregnancy rate, so dismal, just 10 to 20% per cycle. And if we go on to say add on the pregnancies over the next 6 to 9 cycles, just a pregnancy rate of 35%. Of course, what are the causes is what is important. And I think it's very important to understand that who will be the woman who will troubleshoot, who will be the ones who will not respond well. And this is what the literature says: women who have got a high BMI, who have amenorrhea for long, who have lots of visceral fat, where there is hyperandrogenism, clinical or biochemical, and of course, if the AMH parameters are not favorable, that means they have too high an AMH, are the ones who are less likely to respond well, and they are the ones who will be troubleshooting. So whenever you're trying to identify a problem, I think it's better to identify your patient before a problem comes, and therefore identify these women and try to individualize them even when it is clomiphene citrate. So what are the problems of troubleshooting with clomiphene? High ovulatory rates but low pregnancy rates. And what are the possible reasons? Probably it's the anti-estrogenic effect when it comes to the cervical mucus and endometrium, and that's when you get when you use a clomiphene back-to-back. A high miscarriage rate may be the reason why we have low pregnancy rates, high subclinical losses, and a very important thing is an iatrogenic luteal phase defect. Something again which we should understand why clomiphene troubleshoots is when you give clomiphene back-to-back is because this drug has a long-lasting effect. In fact, the half-life of this drug is 42 days. That means the drug will almost take a month to be washed out. So when you see these patients getting repeatedly back-to-back CC, that's a time when you should realize, yes, this could possibly be a reason. And I think in my practice, I never believe in giving a clomiphene in successive cycles. It's always to either break or give an alternative, because this effect on the endometrium is something which really makes you very frustrated. Yes, there is a problem of clomiphene resistance, of course, a problem of clomiphene failure, and of course, endometrium. Now, how do you really call clomiphene resistance? It's basically when you've given them the highest doses and still they don't ovulate. And These are the patients who are likely to give you trouble when they're obese, hyperandrogenic, and of course who have a clinical or any evidence of insulin resistance. So if you have a patient who doesn't respond to clomiphene, what are the options? I'm sure no one of us is following the extended course because this is quite an old guideline, but yes, there are some old timers who would say, yes, instead of giving it 5 days, let's go and give it for 7 to 10 days because literature says that some patients up to 50% may still ovulate when you prolong. The other option is given metformin, and of course metformin definitely is an advantage when you have somebody who is obese or shows other features of insulin resistance. Is there a place of giving pre-treatment with oral contraceptive pills? And I will just share with you literature later on. Of course, there is now the availability of aromatase inhibitors, including letrozole, which is of benefit when it comes to clomiphene resistance, gonadotrophins, and laparoscopic drilling. Now, moving on to failure, that means she's been ovulating, and despite a good ovulation, she fails to have a pregnancy in the last 6 cycles. The causes are all that have been listed here. But then what do we do? Even though we understand these causes, how do we treat them? The understanding is that if it is an elevated LH, which is very difficult to kind of prove, other than somebody who has a high basal LH, could we give them OC pills? Perhaps give them OC pills for 1 month or 2 months, but definitely it's an advantage to give them more than 1 month because giving 1 month OC pills may not be enough. So giving it successively for 2 cycles is of value because what this OC pill will do is lower the LH, lower the androgen, and therefore be of benefit. The other therapy is you can give them progesterone in the form of 50 milligram of shots of 5 days, suppress the FSH-LH, and then take them for a clomiphene. Now, the other options when they fail on clomiphene is add an IUI, perhaps that could sort of do a boost, or maybe consider other options like letrozole or give a combinations, and I'll talk to you later on that. So I don't know if the previous speaker talked about letrozole, but just quickly, this is the kind of patient where letrozole will be handy when she's been tried with clomiphene, she's resistant, she's failed, and of course there is literature now from latest trials that even as a first line, letrozole does good in PCOS. And I think in the mild stimulation as well. So I won't really talk about the mechanism and the details, but this is the landmark paper which actually was done by Casper's group, where they actually used this drug way back in 2001. And this was a group of women who were referred with clomiphene resistance, and they did not respond after receiving clomiphene citrate, and no ovulation was documented. And therefore, when they used it in 2.5 milligrams, they found letrozole appeared to avoid the unfavorable effect on the endometrium. These women ovulated and they had a good pregnancy rate in that small group of patients. If you look at previous papers, again, they show that if you use this in CC-resistant patients, there is a benefit in women who had failed with 100 milligram of clomiphene. They showed that there was evidence of not only improved pregnancy rates, but their endometriums were good despite the lower levels of E2 this drug gives. So definitely, it is a treatment option when there is CC resistance and also when there is a CC failure. So this kind of a troubleshooting can be overcome with the availability of letrozole now. Again, I won't really talk much about the classification, but metformin is one biogonide which we are really using, and it's still I think a complement to clomiphene when patients are resistant or they don't kind of respond and have failure. Of course, it's been a roller coaster. We had metformin come with a big bang and then it's lost. It's kind of failing to distribute. But if you look at the trials, including the Cochrane, which the old says, there was no improvement in the live birth rates, but there is a role of metformin in improving reproductive outcome in PCOS was limited. But if we look at it, its current status after this Cochrane review still says that in combination, CC is superior over clomiphene alone or over metformin alone. So that's one big place where its role is defined. And also, when you use metformin prior to IVF cycles, it definitely attenuates the risk of OHSS or makes the OHSS milder. Now, coming on to the next option, if she's a CC resistant or she's failing, the next thing is gonadotrophins. We know that these women have got tonically elevated LH. So what should be our choice of gonadotrophin is a big question. Obviously, we'll prefer a recombinant over urinary, but one has to think that they have all the goodness. Cost is definitely a factor. But then, is it definitely to be a recombinant? No, not definitely not. I think if you look at this Cochrane review, it clearly says that in women with PCOS who are resistant to clomiphene or who had failed to have a response with clomiphene, they found no difference in the live birth rates or OHSS if they used a recombinant or a urinary. So I think the take is, it is what you're conversant, what your patient's pocket allows, and how confident you are in using urinary. So it's not that. But yes, if your patient can afford, and you know that you can make the patient understand, then it's always good to use recombinant FSH when it is gonadotrophins or PCOS. So what is the troubleshooting when it happens with gonadotrophins? It's definitely an excessive response, which could lead to all the problems, or is it also a premature LH surge, which is a concern? We know that when we have a hyper response, the result is a multiple pregnancy. And if you look at the figures, gonadotrophins are definitely causing much higher chance of multiple pregnancy as compared to letrozole or clomiphene. And of course, the understanding to prevent this problem is that you should keep your threshold to cancellation higher if you have got more than 3 follicles or 4 follicles. Don't feel happy she's getting 4. I think it's a good idea to cancel the cycle if you have numbers which are going beyond 4. Similarly, the risk of OHSS, we understand this is a risk, but look at the difference between clomiphene and gonadotrophins. Gonadotrophins definitely have a higher chance. And again, to minimize, I think cycle cancellation is the best policy rather than kind of pull out with gonadotrophins and land complications. So what is the take if you have this problem or you are worried or the patient has responded hyper in a previous cycle? I think you should look at tweaking your kind of strategy and perhaps maybe give her a combination of clomiphene gonadotrophins or probably combine them with letrozole, or the best is to go in for a chronic low dose step up protocols. And of course, if you know your patient can't afford, laparoscopic ovarian drilling, which Dr. Mamta was talking previously, is also a good option. Now, how do you really go about when you give a combination with clomiphene or letrozole? I think this is something which is called the sequential regime, which one can give because this works out cheaper than pure gonadotrophins and the risk of hyperstimulation is less. You start giving them from the day 3, day 7 or day 2, day 6, either letrozole or clomiphene, and from the next day you can begin giving them HMG or FSH in dosages of 75. That means you are sequentially following the clomiphene or letrozole followed by the gonadotrophins, start them monitoring, and once the follicles and the endometrium is favorable, trigger them. That's what is sequential. In contrast to a conjunctional, where you start them with the clomiphene, but you overlap. That means the start of the HMG or the FSH starts from the 5th or 6th day. But mind you, don't start it before 3 days of clomiphene. That means you should not start from day 2, day 3, because if you do that, you land up an IVF cycle or a mild stimulation protocol, which will perhaps give you 8 to 10 follicles. And that's what you don't want when you're wanting to just stimulate her for a monofollicular development. And therefore, the take should be keep it after the 3rd day, so somewhere like 5th day. And likewise, do their scans, follow them up. And this is one thing which really helps you not only to get lesser chances of a hyper response, but it's very friendly to the pocket of the patient. And you'll end up getting a good response. In fact, this is data coming from a paper from Roy Homburg where they used this. They found that the pregnancy rates were as good as what they got with pure gonadotrophins, and multiple pregnancies and OHSS were definitely lesser as compared to pure gonadotrophins. Now, the other thing is chronic step-up low dose. That is when you have known she's likely to troubleshoot or somebody who's already given you a hyper response. Then the take is start them on lower dosages. Start them slowly. Maybe 37.5 or 75 if you're using a recombinant like Gonalef, or maybe 50 to 100 if you've got Recagon. But the take is that don't start them with small doses, increase them slowly, go increasing not before 7 days. So don't sort of start jumping to increase and escalating the dose if you don't get a response in the next 3 days. You have to be patient. Not only the patient, but the doctor has to be patient, and so you have to counsel your patient. In fact, in this paper, they increased the dosages as small as 8.3 international units. And what they found was an OHSS of 0%, multiple pregnancies of just 5%. So this is something which is brilliant. And if we look at the consensus, which has come from the group, it clearly says that when you're thinking of a chronic step-up low dose, counseling is very important. You have to start them with low dosages. Intense ovarian response monitoring is required, and of course, you should be very strict about cancelling the patient if she hyperresponds.
Sorry to interrupt.
Yeah.
You have about 5 minutes. So
Okay, so I'll just talk quickly about the premature LH surge which occurs, which is there in patients with IUI, and that's another troubleshooting area, and you could give them antagonists to avoid that problem. Now, just a quick word about IVF. Why are IVF patients so different, and what's the problem? These are the problems. These patients are truly explosive for whatever kind of cohort of follicles they have. Their AMH is higher, and that's the problem with these patients. Now, we have got data that not only is their outcome poorer in terms of more oocytes, but their fertilization and cleavage rates are lower. That's proven without doubt. So the problems when troubleshooting are difficult COH. That's what I'll talk, because Dr. Nimesh will talk about the other things. And troubleshooting here is when they have a premature LH surge or they have a hyperresponse, and that's what is the worry. So, can we predict a patient with LH surge? Well, really not. Only those who have a high basal tonic LH are the ones where you can predict. If you look at this, the incidence of premature surge is much higher than what you get in any other patients. So, can you define that? Yes, probably you could monitor them, but that's not possible. Do you monitor them serially? Which day? We don't know. Do you check it on the day 9, 11, or you check them on the HC trigger? But the thing is, if the LHS is going more than 10 to 12 milli-international units on the day 8 or 9, or if there is a jump of more than 2 times, or if there is an evidence of ovulation, or if she shows high progesterone, that means she's showing an LH surge. Now, does LH surge always cause a hump? Again, a big debate. If you look at these papers, these are big data. They said even if they had an LH surge in the IVF cycle, the outcome was no different. They had no difference in the thing. So can we really prevent the LH surge? That's a question. Can we give them agonists? Yes. Those who have an LH surge tendency, I think you can give them agonists. That's something which is important. Though we recommend an antagonist cycle, but then that's what it is. Could we give them OC pills? Yes, perhaps. And of course, progesterone, which I also learned new when I was preparing this lecture from a few Chinese papers, is giving them medroxyprogesterone acetate at the time, or micronized progesterone along with the stimulation is important. So this is a big meta-analysis which says that if you give them OC pills, this is of advantage, and the pregnancy rates were better because they got lesser LH surge with these patients. In contrast to recent papers which say no, it hasn't made any difference. So again, the take on OC pills is not very substantive to say you should give, because these papers say that if you give them in the first cycle, they did not improve the follicular arrest or the rate of LH. So I think it's a big debate. Now, this is what I thought I could share, because I have never used it, but this is what I could pick up from recent review papers or recent clinical trials from China, where they have used utrogestrone, which is micronized progesterone 100 milligram, along with HMG, and they compare it to a trial in patients who are enrolled with a short protocol. Now, they've been very daring. I have never used a short protocol in a PCOS. A short protocol was agonist in small doses on the same day as starting, and what they found was this was all freeze-all cycle, which Jayesh will speak. So they just used this combination and they went on to freeze-all cycles. And then when they thought and they used FAT, they found that the group which had got progesterone along with HMG had higher pregnancy rate. So perhaps this is kind of thought for us to think we could use this. And therefore, if you looked at the profile, they had better, LH parameters. The LHs did not rise in this group. And a similar work which comes from China again, where they used, instead of utrogestrone, they used medroxyprogesterone acetate in the dose of 10 milligrams per day from the day of stimulation. So people who are doing IVF could perhaps kind of try. But if you read these papers, you do understand that when you give these, you have to serially monitor the LH. That's what they did. And a very important thing is that the requirement of gonadotrophins for the cycle becomes very high. So that's an important kind of thing. I again will say that when it comes to comparing the protocol, antagonists are definitely superior to agonists, not because they are good in clamping the LH, but they have a very good safety margin. That is that you can give an agonist trigger and get away for the risk of OHSS, which is a definite troubleshooting problem when you do IVF in these patients. I again won't talk about this because time is less and there is a lot of Cochrane data which is there. So I would again skip these things about preventing the problem of OHSS of talking agonist trigger. I'm sure Dr. Nimesh is going to talk more because he lectures on this. But this is another troubleshooting area, and you can perhaps predict your patients, those who are likely to trigger, to go in for an OHSS, just give them an agonist trigger. And the bottom line is not give trigger, freeze all, and be safe and happy rather than. So if we look at it, this is what literature also says, that this is a method. I'm sure the Cochrane came in 2012, but when they revised, they'll have to say that there is now definite evidence and good evidence to say that we can perhaps go for routine cryopreservation. Now, metformin, of course, this is another area which I think is important to highlight, even though I have less time. You know that this is a patient who's likely to go in for hyperresponse. Giving them metformin for at least 2 to 3 months in advance will of course avert the chances of a severe OHSS. I don't say it'll completely abolish, but it will at least attenuate the risk of an OHSS in these patients. And of course, this is again a Cochrane which says that these patients have done better in terms of the risk of OHSS. A word about myoinositol. This is again initial work. The Cochrane says it doesn't improve the clinical pregnancy rates. But what if you look at the trials that have come up in PCOS patients, they've said that there is an improved insulin sensitivity. I'll just share with you, we've already ongoing a randomized trial where we're using head-on metformin with myoinositol, and there are very few papers which are randomized. We are already undertaken a study. Perhaps by the end of the next year, we could sort of give you the results, because it's a large trial and we have already initiated this. But definitely myoinositol will have a way forward when it comes on risk of OHSS. Now, I thought I'll just tell about a poor response. Don't think that women with PCOS will always hyper-response. There will always be a subgroup who will be giving you trouble. And which is this? This is a subgroup of women who have abnormally high AMH. So don't think that we have to sort of be talking of hyper-response. Rather, with these women, we rather walk a tightrope. At one end, we know we give them a slightly high dose, they will blow up, they'll bloat up. And at the other end is somebody who has a high AMH, may not respond. So in such patients, you have to be very, very precautious. You have to counsel your patients very well. And the reason is always this high AMH actually has a negative impact on the FSH receptors and doesn't let these follicles grow good. Now, how do you overcome these challenges? I think it's very important to define your patients, individualize them, titrate, but all said and done, all that the good you do, you still will have to face the music of some bit of complication, and that's very important. And I think I will just kind of end here by saying it's important to define your variant of PCOS. You know, it's not that PCOS is one problem. There are variants depending on the phenotype, whether she's a pure PCOS on ultrasound or she's hyperandrogenic and is insulin resistant. Of course, clomiphene is the first choice. I can't say letrozole is an alternate. I think we could now say it is the first line. Gonadotrophins have to be used with caution. Antagonist protocols are the best when in terms of safety. Agonist trigger should be a routine if you kind of think there is a possibility of an OHSS. And freeze-all policy is the best way to avert the complications. And all those patients where you feel there is a likelihood, or those who have arrested and have shown a poor response, I think these are the ones who need a further evaluation rather than jumping again with the complication of an arrest. Thank you very much.
Thank you very much, ma'am. I request Dr. Madhurima Tuli ma'am to hand over the monitor to Dr. Neena Malhotra as a token of appreciation. Continuing with our session, the last lecture of our session, it gives me this pleasure to welcome our own and introduce our own Dr. Vinesh Shekhar, MD, FCPS, FICS, FAS, FICOT, FICS, FICMC, VGO, ERP, Vice President Oxy, President SOGS, other Clinical Secretary, sir, and a long list. Let me show you. In the early morning, I was discussing with Shweta about infertility. And Shweta is fond of making some fun. she told me that હવે તો બધા જ લોકો સાહેબ કાઠિયાવાડી લાયકા માંગી છે હવે તો બધા જ infertility specialist એવું લખે છે બધા જ લોકો and there is nothing new in infertility specialist but the person who reaches first at any space he will be remembered always because Dr. Jayesh was the pioneer in IVF in Gujarat. He will be remembered always. I welcome you, Dr. Jayesh.
While they are adjusting the system here, it's my great pleasure to welcome the luminaries of the Indian Fertility Society. Dr. Gauri from Delhi, she is our president-elect. Dr. Neena Malhotra is also from the AIMS. She has brought, and both of them will be, one of them has already given a talk. And we also have Dr. Mamta Dindayal from Hyderabad. She's an old friend of mine. We have been meeting many times in several conferences for decades together. And I'm very happy that we have a gamut of luminaries from all over the country here today. And IFS Gujarat chapter was born through our efforts in the sense that for a long time there was an issue regarding having IFS chapter in Gujarat, and I was approached by the IFS senior office bearers to start this chapter at some stage. This happened for last almost 5 to 6 years. And then another young budding gynecologist from Ahmedabad, Dr.Jayesh, also came up with this proposal. And then it was decided that what should we do? Should we have these chapters divided between north and south of Gujarat? Because Surat is one of the most prominent cities, not only of Gujarat, but of the world. It was the commercial capital in 17th century, even before Bombay came into existence. What Bombay is today is because on the foundations of what Surat gave to Bombay in those days. Very few people know about it if you go back to the history. And therefore Surat's importance cannot be brought down, and we decided that Surat will also have an IFS chapter in the sense that this chapter will rotate every 2 years. The headquarters is now in Ahmedabad. In 2019, it will come to Surat and South Gujarat, and of course that will be the chapter that will be the headquarters of the entire state. So we have all the younger members who want platforms, who want to project their talents, and who want to show the work that they are doing on a very common, uniform, and healthy base with good democratic principles. So I'm very happy to have all of you here. Jayesh has done a lot of hard work in getting this program here, and now let us move on to this topic, which is so important, very, very crucial for all of us, because we have lessons to learn. Let me tell you that volcanoes don't erupt every day. Not erupt every day, but when they erupt, they cause greatest devastation that you can never imagine. And OHSS is one of the volcanoes in gynecology. You may feel, you may think that this is not going to happen. It happens very seriously. I want to just give a quote on what really actually happened to one of our very, very senior revered members in obstetrics and gynecology, very learned person who has written several books on this subject. Very sad, but that person landed up with a young patient who went into hyperstimulation. She did not come back to that clinic. Later on, she went to government hospital. She was treated there, but there she died. And it is very sad that there were certain legal issues involved. This very competent gynecologist was taken up for criminal offense because unfortunately this girl was underage and she was less than 18 years old. It's very, very sad that this gynecologist is unable to practice in our country. He has to go out and practice. And I'm telling you that please don't ever take OHSS seriously. Please don't take it lightly, because it's one of the things that it can happen anytime in your clinic. And I have seen this happen even in our city. One of our senior gynecologists who is also sitting here and who has been on to the teaching side in the medical college, he has also been many times called in. I have been many times called in to see patients who have undergone OHSS, and some of these patients have also not survived in ICCUs of major hospitals in this city. The young gynecologists who feel that they want to do IVF and get into infertility must learn this lesson, that they should not go on stimulating patients without monitoring, and this is a lesson that you should learn. This talk will focus on how you can prevent OHSS. OHSS pre-clinic is one of the biggest aims of today, and therefore, how do we define it? Because the definition is very important. This is a pathophysiological crisis involving growth of large number of eggs subsequent to gonadotropins injection, leading to high level of hormone release, enlargement of ovaries due to stromal edema, and multiple hemorrhagic uterine cysts, coupled with large shift of circulation to peritoneal, pleural, or pericardial cavity, causing hemoconcentration, leading to thrombosis and fall in renal output. So this is the real definition in shortest that one can ever put into the situation, and the whole body, the entire system goes into a severe critical stage. This will have its own degree, but what is the incidence? It is just 1 to 2%. So if you have stimulated 100 patients, out of that 1 to 2 may go for OHSS. Polycystic ovarian syndrome is a major predisposing factor. The difference between PCO and PCOS is very brilliantly shown by Dr. Mamta, who spoke before. Now, when you have more than 20 follicles grown per ovary, the estradiol level more than 4,000 picograms per ml, and aged above 40, you can be very, very sure that you have this particular risk occurring. In the younger patients also you have this problem. Predisposing factors are, of course, estrogen, the levels of estrogen, the human chorionic gonadotropin effect on renin-angiotensin system is also one of the predisposing factors. Histamine, prostaglandins, endothelial growth factor, aldosterone, angiotensin 2, and interleukin production, and tumor necrosis factor alpha. These are the various predisposing factors which lead to OHSS. Now, we can have mild OHSS. Many of our clinics do have mild OHSS, and the patients will come with abdominal heaviness, tension, swelling, pain. And on ultrasound, what we will find is a bilateral ovarian enlargement by multiple follicular and corpus luteum cysts up to 5 centimeters in diameter rupture and torsion of cysts. So this is the way that we get these patients presenting to us. The moderate ovarian hyperstimulation occurs within 10 days of HCG administration. There will be nausea, vomiting, occasional diarrhea also, and there is always some weight gain because of fluid accumulation. There is increased abdominal circumference, and on ultrasound you will see ovaries enlarged up to 5 to 10 centimeters in diameter, and also ascites. If you have a severe, which is a rare thing, but it can still happen, as I said, a severe ovarian hyperstimulation syndrome can present with ovaries more than 10 centimeters in diameter. And the thing is, these patients present with pleural effusion, pericardial effusion, hypovolemia, hypotension, impaired renal function, oliguria, electrolyte imbalance, disturbed liver function, thromboembolic phenomena, which is, of course, leading to hypercoagulation, shock, dehydration, tension ascites, and adult respiratory distress syndrome, that is ARDS. So you can see that on all fronts, this is a war which we will have to fight on all the systems. If you think that you can fight only kidneys, forget it. You will need a multiple help from various specialists when your patient is admitted to intensive care unit for OHSS. And if you feel that there is a risk that this patient is going to undergo the 3rd degree OHSS, please don't hesitate. Put all your egos aside, send the patient to a tertiary center, admit her into an ICCU, and summon help from your seniors and the multidisciplinary gamut of consultants who are nephrologists, cardiologists, pulmonologists, and the other experts who are linked with this particular problem. Ask their help and see that you try to save these patients, because death is sure if they are not checked and treated at the right time. Factors are patients who have undergone surgery for benign ovarian cysts. Patients with unilateral oophorectomy are more prone to develop OHSS upon have a clomiphene site reducer for induction of
ovulation, because they have just one ovary, but the dose that you give is normally given for 2 ovaries, and this single dose focuses on that ovary, and these patients ultimately go for hyperstimulation. Prevention is most important. We all want an OHSS free clinic, and our aim is how do we do it? See, important is monitor induction of ovulation. What happens is there is tremendous rush and tremendous urge in the younger generation, which is coming up from the gynecological field. They all feel that IVF is the only goal for them, and they want to start IVF as early as possible. They want to induce patients, and nothing wrong in it. There is a big wave for IVF all over the world, and maybe in India we have also infertile patients. We should be treating them, but please try to understand that all patients will never need IVF. You have to be very careful that if they can be treated by other simpler means, please try to do so before taking them up for IVF, even if you have the facility. And therefore, when you induce them for ovulation, you have to monitor them very carefully. There should be measurable parameters which accurately reflect follicular maturation. The clinical evaluation must be done by cervical scoring, and serum E2 levels, you must know that OHSS can occur at 1500 picograms per ml. Don't be in the delusion that it will occur, it's just 2000, it is less than 2000, I'm safe, or our clinic is safe, and this patient will not get it. It can occur at 1500 and is more risky, of course, if you cross more than 3000 picograms per ml. Now, E2 values more than doubling during 2 to 3 days is a serious warning sign of steep slope rise, and HCG should be withheld in that cycle. So, if you have done serial estradiol monitoring, if not every day, every alternate day, and if you find that these numbers are multiplying at double or treble levels, you should be very careful that if you give HCG, this patient is one of the sure candidates to go into ovarian hyperstimulation. So do not give HCG in that case. Don't hesitate when you have these patients, because there are fertility senior experts in your all major cities that you come from, and there is no harm in calling them, because they are all your colleagues. They will not hesitate to help you. So I'm very happy when I receive calls from junior gynecologists who are practicing and who have got in the middle of the cycle, they find that the levels are going high, and they take my opinion on this, and I try to help them that if they think they should withhold, then better withhold, and we don't want serious risk involved. So if you find ultrasound more than 8 follicles, estradiol level more than 4000 picograms per ml, and on ultrasound you find more than 15 follicles or more than 12 millimeters in diameter, 2000, then you must delay HCG. Now, when you delay HCG, it is called ghosting. Ghosting is what that if you have a ship, it has moved right into the sea, and you find that the waters are getting troubled, the waves are rising. Oh, there is a risk of tsunami when somebody from North Korea has blown up a hydrogen bomb. Well, this is where you have to find that you take away your ship back to the coast and don't try to sail in those troubled waters. When you find that estradiol values are more than 6000 picograms per ml, this is a cutoff value, it is a big warning sign. What you should do is delay HCG, continue GnRH, and withhold your HMG or whatever stimulation you're giving, FSH or HMG, till estradiol levels they fall below 3000 picograms per ml. So, because you have delayed it and you have coasted out, a little more back into the safe waters. If you still try to move into the middle part of the sea, into the deep sea, you will end up in big tsunami waves. Come back, come onto the coast, sail in safe waters, and once these levels and the waves come down, you are safer to drive your ship, and then you can give HCG. Now, you must complete follicular aspiration. Another thing is, if you feel that there are too many follicles, this is another option. You aspirate those follicles, don't leave them inside, because that will reduce the discomfort of the patient, it will reduce the distension, and one thing is that if you aspirate follicles of one ovary prior to HCG, they may not have effect on prevention. So give luteal phase support. Now, since HCG increase the chances of OHSS, progesterone, of course, is solely given. Progesterone antagonizes high estradiol levels, thereby reducing the chances of OHSS. So in case if you feel that nothing is working, give progesterone. Progesterone is a very important panacea when you are sailing through these difficult times. And of course, there are various other options, including steroids as well, but progesterone is very important. In a PCO patient, you can prevent OHSS. You can do laparoscopic ovarian drilling prior to stimulation, decreasing the chances. That is, of course, a low dose of recombinant FSH used in stimulation protocol. I think Dr. Pooja Nadkarni talked on the step-up protocol very nicely about recombinant FSH and the 37.5 incremental doses. This is also one way of preventing PCO, OHSS in PCO patient. Particularly today, this symposium is on PCOS, so we will stick to OHSS in PCOS. Now, posting should be done till T2 levels drop to a half in 24 to 48 hours. And that is the way that then you can move forward into the treatment. Now, another option and another modality, post-oocyte retrieval albumin as a prophylaxis. Now, how does albumin work? It helps by increasing oncotic pressure, helps in controlling and sequestering vasoactive substances released from corpus luteum. With OHSS, what happens? There is a very big shift of fluid from the compartment, the vascular compartment, into the interstitial compartment. When you give albumin, the oncotic pressure increases. It tries to retain fluids back into the vascular compartment, and it sequesters vasoactive substances. It tries to stabilize the system and the disparity in fluid change compartments. Another option, of course, cryopreservation of embryos and subsequent replacement. Here I'm talking of embryos and not oocytes. OHSS increase with SCG released by pregnancy itself. So if no embryos are replaced, no pregnancy occurs, and OHSS increases by 10 days. So you have encountered mild to moderate ovarian hyperstimulation. If you still replace those embryos, that embryo and the trophoblast, if it implants, is going to secrete HCG. And that HCG again is of a higher dose, mind you, because what trophoblast can secrete, your injections are khichdi compared to that. So that natural trophoblast is going to aggravate the ovarian hyperstimulation, and if pregnancy has occurred, it is going to be much more difficult to treat these patients. So sometimes even termination of pregnancies are advocated if things go out of control. So it is very sad that for the very purpose that you took this patient, try to treat her, give her a baby, you have to actually terminate that pregnancy to save her life. Now, subsequent replacement of embryos in a non-stimulated or a natural cycle ensures freedom from hyperstimulation and good pregnancy rate. So it is better that if you have encountered that this patient has a risk of OHSS, retrieve those oocytes, get the embryos developed in your embryology lab and freeze them. Do not replace them. That is one way of, again, preventing OHSS. And use of GnRH antagonist is always, I mean, that is one biggest revolution that has come back in endocrinology, in reproductive endocrinology, because till the time that we did not have antagonists, and we have gone through that phase because we are one of the initial IVF workers in this country. There were only other 8 centers of IVF when we started the first center in Gujarat, in Surat, way back in 1991, and we did not have antagonists at that time, and we had to use agonists, and it was a terrible time to sail through. When the antagonists have come, it is a great blessing for the younger generation who deals with IVF, that hardly will find stimulation or hyperstimulation with antagonists. So unlike GnRH agonists, the antagonists are able to prevent OHSS due to less dosage of gonadotropin required for ovarian stimulation. So this is one very important march in the advances. Short protocols of ovarian stimulation have less risk of OHSS than long protocols. So try to avoid long protocols as far as possible. Now, prevention of OHSS of higher degree in at-risk patient in mild to moderate cases, you must observe general condition, watch respiration, pulse, temperature, weight charge, abdominal girth, fluid input and urine output charts. Liver function tests, which include SGOT, SGPT, albumin globulin ratio proteins and serum bilirubin, renal function tests, serum creatinine, urea, electrolytes, serum electrolytes, sodium, potassium, urinary sodium and potassium, and coagulation factors. Those have been activated prothrombin time, bleeding time, clotting time, and platelet count. These are the factors which you have to monitor, and it's important. I remember my first case which underwent OHSS. It happened about almost 18 years ago, and I they just did not leave the ICCU. I just stayed in the ICCU for 3 days without leaving the hospital. We could manage to save the patient, but it is a very, very terrible situation to face if you have an OHSS patient who is very, very critical. The blood gases which you see that you have PO2, PCO2 with acid-base balance, and pH and pH which you have to monitor. Serum beta HCG, you have to diagnose early. If you can diagnose it early, of course, it helps in diagnosis of early pregnancy and in the line of treatment. So these biochemical tests are extremely required. On ultrasound, monitor ovarian size, check for ascites degree, hydrothorax, single or multiple pregnancy, and this will help you to go further in your diagnosis and treatment. Now, how do you prevent catastrophic death? Because this is something which we don't want. The entire faith of the patients that we can treat their infertility, give them pregnancy, give them a baby, give them the next generation to live. That faith rests on the fact that we save these lives. Medically, you have to control circulatory and electrolyte balance, restore normal intravascular volume to assign normal renal function. You must have 20% of albumin with colloidal plasma expanders like intravenous hemaxil, prophylactic heparin maintained for prolonged periods in hypercoagulation profile detected biochemically, diuretics in pulmonary congestion, edema, indomethacin can be given to decrease capillary permeability, dopamine in oliguria for renal function. So these are the various drugs that I use. Under ultrasound guidance, how will you surgically, how will you prevent it? Abdominal paracentesis can be done on ascitic fluid when discomfort increases with dyspnea and vomiting. Post-tapping albumin given to compensate protein loss, and of course, because a lot of fluid, when you aspirate, this albumin and proteins will be taken away from the body. So see that the patient does not get hypoproteinemic, and we have to replace these proteins. Transvaginal guided aspiration of ascitic fluid from the pouch of Douglas, and you can also do unwinding of torsion of cystic ovary. This is a rare complication, but when the ovaries get enlarged and they become very, very heavy, they will move on their pedicle with increase of fluid inside the abdomen and ascites, and they rotate in such a way that the entire pedicle gets twisted. And once it gets twisted, if it is not untwisted, these ovaries can go necrosis and total ovarian failure, because the blood vessels, they get totally closed with that torsion, and sort of a pseudo-knotting takes place. Good laparoscopic surgeons can unwind this torsion. We have seen those in the films, and I can see that it is possible to save these ovaries. So be very careful, monitor these patients with ultrasound. Even when they are in ICCU, beware that these ovaries do not undergo torsion, and that now with color Doppler studies will be able to detect torsion easily.
Extremely sorry to interrupt you, sir.
Yeah.
You will
Yes. Laparoscopy must be considered for hemostatic measures, rupture of the cyst, ectopic pregnancy, and when this is all what we mentioned. Laparoscopic surgery is best avoided in compromised case where there is massive hypoconcentration and hypoperitoneum can further compress inferior vena cava and compress cardiac output. So in conclusion, OHSS is a preventable condition in majority but can occur in unexpected situations. Don't be overconfident. Don't think that everything is going smoothly. It can happen anytime. Means to prevent OHSS depend widely upon clinical judgment and controlled use of drugs and ovulation. I think you all.
I request Dr. Jayesh
कौन सा है लैपटॉप चेंज वायरस है भरपूर वायरस है SOGS पैनल ये है ना नीचे वाला पक्का हाँ बस 51 SOGS पैनल चेंज करो देखते हैं
Now I request Dr. Vijay Ronker sir to present token of thanks to our dear Professor Dr. Narendra Bhatt.
હમણાં છે તમારું છે
I request Dr. Meghna Shah to present moment to Dr. Now we move on to our next session. I request Chairperson Dr. Rajesh Suri sir and Dr. Nilima Bhargava to chair the session. Dr. Nilima Bhargava is a renowned gynecologist practicing since last 2010 in Evergreen Hospital. She has work experience of many multi-specialty hospital of Jaslok, Sardar Smarak, Ramavi, Nursing Hospital, and Nilima Hospital. Dr. Rajesh Suri sir. He is the present president of SOGS and senior gynecologist practicing since last 27 years. I request her to introduce the speaker.
Good morning, audience. Invite our speakers, first of all, Dr. Jayesh, for the first. As you know very well, Dr. Jayesh is the person who actually is secretary, IFS, Gujarat, and the person responsible for organizing the show in a very big way. And he is infertility expert, having a number of papers, a number of journals in which he has given his papers, and been also faculty in IMA, has numerous articles published in Indian journals IMA, invited as speaker at SOGS in December 2009 on optimizing IY, and also been faculty panelist at ISAR 2012. These are just a few. Besides that, there is a big list which you can see over here on the screen. He not only was national but had also been a national speaker on surrogacy of India, and been international speaker on best practice in surrogacy in London in March 2015 also. Besides that, had a very good work done in the infertility, having the interest area in focus on troubleshooting infertility and IVF, with special interest in hysteroscopic surgery and recruitment of IVF failure. I request Dr. Jayesh to please come, the person who actually is an expert in recurrent IVF failures.
First of all, really thankful to Surat and Gynecology Societies, all the people together here, together, very high academic list. Must congratulate the team leader of at present SOGS Society, all the seniors, and warm welcome to my all national speakers, Dr. Dayal, Dr. Neena Malhotra, and Dr. Govind. We have started this IFS chapter, Indian Fertility Society, installed in 30th July. This is the second academic event which is held in here in Surat. So we'll come directly to the topic. Freeze-all, is it a future? So freeze-all, is it a future? So I'm not talking only on the hyper-responder, I've been talking in general. That freeze-all, is it a future? The question arises in my mind, what is the need of freezing? Why? Why we need freezing? And if you consider the answer, the first need for arising of the freezing in hyperresponders, as we are talking by Dr. Manish and all the speakers, that OHSS, And we know that the incidence of OHSS and sharing about the morbidity and mortality, this is what we are sharing in front of the papers, that this is the morbidity and mortality in the OHSS, which is not accepted. In 2000 up to 2008, before the launching of the antagonists, 1984 to 2008, 3 deaths will be there. 2 is from this respiratory distress, everything. So it means we have to stop this OHSS morbidity and mortality. And for that, yes, we need a freeze-all protocol because it is completely going to give the OHSS free cleaning. That will I come to next slide. The next slide is thinking about not only hyper-responder, as we thinking about the success rate of the IVF, then we know that it is something like some clinics narrate is 35%, some papers will say it is 25%, 28%, 40%. The review of some articles, randomized control trials say it is about 40 to 43%. But when we are interested to improve success rate, it is just limit of the success rate. Is we improve the success rate, and this is the second need of the freezing, is that yes, can we improve? As we know that IVF success in stimulated cycle is between 30 to 35%, and 9-month carry-out pregnancy about 25 to 28%. Is it improve it? Yes, this is the need of freezing to improve the success rate. So to decrease the morbidity and mortality and improve the success rate, the implantation rate, need of freezing will be there. So practically there are 2 big questions: prevention of OHSS in hyper-responder and improving IVF success in normal responder and poor responder. And this is a good paper. What we can say that the concept of an OHSS free clinic has become a reality. And this approach should include pituitary downregulation using a GnRH antagonist, that means antagonist for all, in all the hyper-responder, and the ovulation triggering with GnRH agonist. That means you can go by a GnRH triggering, agonist triggering for all, and vitrifications of all the embryos. If you want to make OHSS free clinic in all the patients, then yes, freeze all is a good strategy. Even after leupride trigger, the leupride triggering, you know that the success rate of IVF is so down. So to improve the success rate, again, the freeze all policy is better in the hyper-responders. Why low implantation in stimulated cycles? Why there is uncertainty of results in beautiful triple-line endometrium with grade 1 embryo transfer in stimulated cycle? The question arises, and the answer is, we know that. The reasons, we know that the genetic uncertainty of the embryo, the losing of the window period of endometrium of implantation, which is generally 19 to 24 of the day of the cycle. Sometimes we are thinking about the immunological course regarding the implantation figure. Sometimes we are thinking that medically unfit patients like thyroid and diabetes and hypertension, which is associated with the patients. But we know that we can manage this immunological cause, we can manage that medically unfit patients, and we can go by a genetic screening like PGD and PGS. But what about this window period? What about this window period? That is more important, and that we have to know that what is endometrial advancement, how this window of implantation period is going to be shifted. And that we come to know that ovarian stimulation is having a direct effect. What effect? Stimulations with exogenous FSH promotes development of multiple ovarian follicles. The multiple follicles produce supraphysiologic level of estrogens, progesterone, and other hormones. And these hormones affect and control endometrial development, maturations, and uterine contractile activity. So endometrial changes, the mature penopods appear 1 to 2 days earlier in cycle with controlled stimulations are less numerous, and penopod functions not yet confirmed, but generally believed to have a role in implantations and endometrial receptive phase. So progesterone receptor downregulated 1 to 2 days earlier in cycle with controlled ovarian stimulation. So advanced endometrial histology, if we confirm by histology, it has been proven by the studies that advanced endometrial histology has been correlated with premature progesterone elevations and implantation failure. gene expression profiles, the gene expression profiles are different between natural cycles and the cycles of controlled stimulation, consistent with dysregulation of gene expression in hyperstimulated cycles. So many genes associated with the implantation window on SCG +7 were delayed by 2 days, and this is consistent with histological and biochemical and discrepancies and previously in the other studies. So what is the conclusion? Overall effect of ovarian stimulations on the endometrium is following control stimulation, the endometrium is histologically advanced, biochemically different, and genomically dysregulated. The question arises how to find out clinically. We know that we can do a biopsy, but dating is not correlated with the exit window period of the implantation. It is failed. We know that the test is available where we can find out the pre-receptive and receptive and post-receptive endometrium, but it is more required in the multiple IVF failure, and it is required when you are, it is a costly test. So is it something like that, any other test that we can find clinically? How to find out clinically? Is there any correlation of endometrial advancement and the estrogen and progesterone level in the serum? Is high progesterone shows less implantations? And the answer is that one Varenberg et al. 2011, they have a study about progesterone level less than 0.9, 1 to 1.5 progesterone on the day of SCG, and more than 1.5 nanogram per milliliter on the day of the SCG. And they studied the gene expression analysis. Amazing, you see the B group and C group when the progesterone level on the day of the SCG is 1 or more than 1.5, the up regulations and down regulations of the gene expression is very higher. It means this is the first study to demonstrate a distinct difference in endometrial gene expression profile between patients with a progesterone serum level above and below the threshold of 1.5 nanogram per milliliter on the day of SCG administration. This is the same thing I want to tell you, and this is progesterone rise. Van Varenberg et al. 2011 demonstrated that progesterone rise on the day of SCG FSS stimulated cycle affect endometrial gene expressions. So you can measure the progesterone level. And this is a one study, very good study. What it says something, Bosch et al. In 2010, the number of the oocyte association with the progesterone level. They said as the number of the follicle, as the number of the follicle retrieval rate is higher, the estrogen rate is higher, the progesterone rate is higher. So again, is that number of the follicle, cutoff limit more than 15 follicle, you might have a more than 1.5 progesterone level. Very beautiful answer of Bosch et al. In 2010. They are saying that either you are using a leupride agonist, loop down regulations, long protocol or short protocol, the progesterone level is not going to be differentiated. It is always depending upon the number of the follicle and number of the estrogen level that is stimulated by your cycle. So that is not like that you can regulate the cycle or decrease the progesterone level by the leupride protocol and antagonist protocol. The system is not going to control the progesterone level. It is not like both systems are having the same effect on the progesterone level. So that it has been concluded that the higher estrogen level, the study concluded that higher, more than 15 follicle or more than 15 oocyte retrieval will have a higher estrogen level, will have a high cutoff of the progesterone level of the 1.5, and that's why. This is the last study, which is Fatemi and Van Varenberg in 2015. They concluded, they are not saying zero result. They are saying that it is clear that high progesterone during the follicular phase jeopardizes the endometrial receptivity. That are less implantations, less chances of implantations. And this is again supported in the 2010 by Shapiro et al. What it says that high progesterone level, it is having a less pregnancy rate, ongoing less pregnancy implantations, and the abortion rate is higher. But after all this thing, when we are measuring the serum progesterone, the conclusion is it serum progesterone is the only demarcator where we can transfer and not to transfer? Is it like that when serum progesterone level is less than 1.5, you will get a better output, better implantations? No. And that is the right condition I want to tell you in this study, that this is a study which shows about the 530 cycles were including, were 351 in the fresh ET group, and where the progesterone level is less than 1.5. And another patient is 179 patients, those who just go for the freeze-all policy. What is the conclusion? Conclusion is the freeze-all policy is having a higher result of implantations compared to those who are having the progesterone is less than 1.5. So what we can conclude is still freeze-all policy is having a higher implantation rate compared to the low progesterone group. So this is a good message that progesterone, doing the progesterone in the IS cycle, which is going to improve the success rate. I will say no. Again, freeze-all policy will going to improve the implantation rate and pregnancy rates. Now, this is a good question, that if supernumerary second-based frozen embryos implanted more readily than the fresh primary embryos, then could further improvement be realized if best primary embryos were cryopreserved in a freeze-all cycle and replaced in an FET cycle? Means you are saying that you are transferring a very good embryo in the first cycle, in the fresh cycle, and second base embryo in the next FET cycle. Why not we transfer the base embryo in the FET cycle? Could it improve the success rate? This is the question, and question will be answered. We'll know that there is a biological variation in embryonic development pace. So some embryos from expanded blastocyst on day 5 development, other on day 6. Blastocyst implant more rapidly than day 6 blastocyst in fresh IVF cycle following ovarian stimulations. So Shapiro et al. It says something like that. If you transfer in fresh cycle day 5 blastocyst, then you are having a more result compared to you are transferring day 6 blastocyst in the implantation part. So this is again a question. Why do fresh day 5 blastocyst implant more rapidly than the fresh day 6 blastocyst? And day 6 blastocysts have different implantation rate in FET cycles, or if day 5 and day 6 blastocysts have similar implantation rates in FET cycle in the absence of controlled ovarian stimulation, should they have also similar rates in donor oocyte cycles? So these are all concluding that what is important at least all or transferring in the same cycle. And conclusion, the retrospective study is there in 2008 of Shapiro et al. 377 fresh autologous cycle, 106 autologous FET cycles, 56 fresh oocyte donation cycle. Will say that in fresh cycle day 5 is pregnancy rates is higher compared to day 6, but in FET cycle you can see that day 5 and day 6 the success rate will be the same, and if you see the fresh and donor day 5 day 6 almost the success rate is the same. So that means the endometrial advancement theory is the only culprit not to have a better implantation rate. So the conclusion is that day 5 and day 6 blastocysts have a similar aneuploidy rate, similar implantation potential in frozen thought cycle. Day 6 blastocysts transferred in cycle without ovarian stimulation implant more rapidly than day 5 fresh day 6 blastocysts in cycle with ovarian stimulations. Conclusion is the different implantation potential between day 5 and day 6 blastocysts is consistent with advanced endometrial development in cycles of ovarian stimulation. So that slower embryos are less likely to implant because the endometrial receptive phase ends prematurely. That means it is prematurely, and that's why the implantation rates are lesser. So how does FET young patients compare to fresh donor using young donors? This is more important. Very good slides. What it says, compare 205 autologous FET and fresh oocyte donation cycle, and that is again are saying that if you are doing the day 5 FET, fresh donor FET day 5, the results are same. Then again it will suggest that endometrial advancement is the only reason that you are getting a less results in the day 5 implantations. conclusion, in the absence of cryo damage, FET embryos can implant as rapidly as those from fresh oocyte donor cycles. So could there be embryo screening effect in FET cycle? This is more important. Somebody are saying that, sir, we don't have the supernumerary embryos are having a not good results. So we are having a very bad results in FET. But it's more important, your morphological screening is more important. And how you are doing a perfect morphological screening and the embryo, this is what you are freezing, it is qualitative, then you can compare your success rate and the FET technique. So if you control or your embryo morphology, would fresh and FET implantation rates still differ? Could the difference in implantation and pregnancy rate between fresh and FET cycles be due to screening effect, so that only the morphological based appearing embryos remain after cohort transfer? The conclusion is very fine. Better output when the morphologically based embryo will be transferred in the freeze. So the study is very small, but still it is published in the Sapiro et al. In 2012 infertility sterility. It is a very small study. So what it says that yes, freezing having a better advantage over the implantation rates. Comparing the fresh and frozen embryo transfer of 103 normal responder, you find out again the FET is having a higher growth, higher pregnancy rate, higher implantation, higher ongoing pregnancy rates. When compared to fresh transfer, embryo cohort cryopreservation followed by frozen thaw transfer has been associated with. Now we are worried about that if we do the FET all, then what happened to the perinatal outcome? What happened to the other outcome like antepartum hemorrhage, eclampsia, diabetes? What happened to that? But studies are very confirmed. It reduced the risk of implantation failure in normal responder. It reduced the risk of implantation following premature progesterone elevation. It reduced the risk of IVF failure per retrieval. I would like to say, when compared to the fresh transfer and frozen, have reduced the risk of late onset of OHSS. It reduced the risk of ectopic pregnancy in the frozen cycle. The frozen cycle reduced the risk of preeclampsia, and the frozen cycle will reduce the risk of low birth weight, reduce the risk of small for gestational age, and only one threat is greater, means large for gestational age. Very few small studies are saying that FET cycle is having a risk of large for gestational age. So frozen cycle reduce the risk of preterm birth, reduce the risk of preterm low birth weight also. Fresh transfer, frozen thaw transfer has been associated with the risk of less antepartum hemorrhage, less placenta previa, less placental abruptio, and less placental perinatal mortality. So that is what we are thinking. In hyperresponder, we are concluding that yes, we want to prevent the morbidity and mortality, that we are going on freeze-all policy. In normal response, studies are very small, but still in favoring on the better implantations and decreasing the risk in the favor of FET cycle. Now, what about the poor responder? The studies are not still in the poor responder. Even I can say there is no any RCTs, nothing, no study. Very small patients article is there, and I'm putting in July 2016 in the ASHRAE meet. What they are saying still, IVF protocols involve the transfer of a fresh embryo to the uterus during the same cycle, in which the eggs were collected, and freezing extra embryo for the future use. A novel approach to improving IVF confidence has recently emerged, in which all embryos generated from an egg collection cycle are electively frozen and transferred in the subsequent cycle. Means in the poor responder, these people are saying that yes, it is still improving the IVF success rate. So still there is a lacking of the evidence. I would like to share some trends. What the trends in the other countries? Poor responder trends in the other countries. You can see after 2011 in the US, the FET cycle after 35 years of the age is increasing. If you see that after 38 and 40, after 2010, the FET cycles rate is increasing to improve the success rate because of the PGD and PGS and getting a better qualitative embryo transfer. Again, if you say something like that, and more than 48 years of the age, the FET rate is higher. Still, the lacking of the evidence and no randomized control trial, what the ASHRAE guideline is saying that we should have some SWOT analysis. So I will putting some SWOT analysis of freeze-all policy. And what is the SWOT analysis? What is the strength? Freeze-all is increase maternity safety, OHSS free clinic. This is the strength. Improve pregnancy rate. This is the strength. Lower ectopic pregnancy rate. This is the strength. And better obstetrical and perinatal outcomes. So this is the strength, but we have to see the weakness, and the weakness is there. Evidence only 3 randomized control trial is there. So we are waiting for the more large randomized control trial. I know that a lot of clinics are not waiting for RCTs and they started freeze-all, but still I want to say, to deliver a message on this dais, still I want to say that evidence is required. Even cases of OHSS with GnRH agonist trigger, we see that this is the weakness, that freeze-all is required. And if we see the threats, the opportunity, see, every clinician is opportunistic. So what the opportunity they are getting in the freeze-all policy, I can say something, they can stimulate with the higher dose and getting the more oocyte, this is the opportunity. I can say that they are scheduling. We know that scheduling their IVF cycle. I know that you have got a one paper which says that in the luteal phase, even you can stimulate the ovary. There is no any effect on the oocyte quality. That means the progesterone level is higher even in the luteal phase. Even you retrieve the oocyte is having no effect. So the day of stimulation in our fertility is day 2, day 3. Even you can stimulate on day 6. Even you can stimulate on day 7. Forget about the dominant follicle. You can stimulate and you can do for the freeze-all. So no scheduling is required. No Saturday, Sunday off will be managed. And I would like this, the stimulation starting at any day of the cycle. This is what I am saying. And patient friendliness. We know that when we transfer the embryo in the stimulated cycle, patient is always complaining, I have this pain, and they are not comfortable. But when you do freeze-all, they are very comfortable to transferring the next cycle. Threats are there. The change in current IVF practice might be required some observation studies. Optimization of cryogestation technique. This is most important. See, on the behalf of the dais, I cannot say freeze-all is applicable in each and every IVF clinic. It should be optimizations of IVF clinic, how they optimize the techniques, the day of transfer. This all is so important. When it is stabilized, it is always, this is the threat that if we consider freeze-all and somebody is not doing a good freezing technique, the day of freezing is not stabilized, again the results have become down. There is an issue. Only one study is saying that the cost is decreased, but there are a lot of things are in the discussion. As you know that in the Europe and USA, the cost is backed by the government. They have an extra cost of freezing. So people are believing that if you are doing a freeze-all policy, they will get extra cost if there is a freeze-all policy, because they don't have any implantation, 15-25% implantation chance. Yes, last 2 slides. So the average ongoing pregnancy rates at fertility center of Las Vegas, where it says that frozen throat embryo transfer will be higher. Now, this is a beautiful, why I am showing that. I know that there are a lot of clinics are doing freeze-all, but still they are not coming on the dais and saying I'm doing freeze-all, because they are saying that I'm waiting for RCTs. I'm waiting for RCTs, and this is what I'm saying, the world's busiest clinic, Kato, Japanese clinic. No fresh transfer at all, 800 cycles per month, no fresh transfer at all. Electively freeze all the embryos, transfer only in the next cycle, only blastocyst, only vitrification. This is now the gold standard treatment, what the Katos are saying. So, if you believe the world busiest clinic, they are already started. Now I'm sharing all the experience. Why not I'm sharing my experience? I'm sharing my experience at Wings. This is, I do not have any comparison study, but I do have my 798 patient last where we are doing freeze-all, and I would like to share you the results is 503 patients are positive and 295 patients are beta HCG negative. Again the reports, the results are improving 63%. And if you find out the morphologically based, if you find out the age where I'm knowing that aneuploidy rate is higher, if you cut out all this from this whole 798 patients, you'll have a better output in the implantation rate. This is not we observed in our clinical practice. So again, I will be putting my more efforts toward the freeze all where it is required. So the answer is freeze all is the future. Then I will say freeze more is so necessary. Why? Because to prevent OHSS in hyperresponder, improve the success rate and decrease the cost of IVF. I believe I am decreasing the cost, that I have to prove it, and the studies is required. And whereas improve per cycle transfer success rate in normal responder, in poor responder, accumulating genetic material, because we are doing PGD and PGS in more than 35 years of the age. If the patient financial permission is there, then we can go by PGD and PGS. So we have more cryo accumulation in poor responder, low AMH. We can accumulate the embryos, and then we can transfer a good selective embryo in the natural cycle. I believe why in poor responder to transfer, why we are having a hurry to transfer in the same cycle, as we know that we are having only qualitative embryo is 1. Only qualitative embryo is 2. And we are transferring in the environment of endometrium where we are not knowing any taste, because we don't have any taste that this endometrium is advanced or not. But we know that if we transfer in the natural cycle, all HRT cycle, the implantation rate is higher. I now believe in low AMH, and all the people, those who are having more than 35 years and doing cryoaccumulations by the permission of the patients when the economy is permitted, and we can transfer in the next cycle. So our criteria not to transfer in fresh cycle, more than 15 egg collection, suspected OHSS, previous 1 or 2 IVF failure, all poor responders, serum progesterone level I am doing, previously I am not doing, now I am freeze all. So less than 4 blastocysts, yes, this is more important what I am doing. When less genetic material at the end of the day, if I am having only 2 embryo which is collocating in normal responder, sometimes you are stimulating normal responder 20, 15, 12 eggs, but the sperm factor is so bad, you end up with the only 2 qualitative embryo. Now, either I transfer in the environment where I know what is the implantation. Why should I not freeze when I'm so comfortable that that embryo is having 100% retrieval after the thawing part? So I will freeze it, and then I will transfer in the next cycle. I will never transfer the embryos in the thin endometrium where implantation is already decreased. Why should I transfer in the same cycle? I can go in the next cycle, and I will transfer in the next cycle. So the conclusion, freeze all in PCOS patient, freeze all in all poor responder or genetically insufficient patients where embryo collection is less than 4. And the conclusion, this is the best thing I want to share you, that the major advantage of a freeze all strategy is the potential of eliminating OHSS, enhanced cycle scheduling, and improved organization of the IVF unit are elements that should not be overlooked. Taken together, this development may lead to a new era in modern ART. Develop a non-invasive clinical tool to evaluate endometrial receptivity. So we have to just aspirate, and we can know whether it is really receptive or not. Then in the future, we can transfer the embryo in the same cycle. Nevertheless, confirmation of the clinical benefits of freeze-all strategy, though well-designed clinical trial, is mandatory real to shifting our current ART practice. I believe that. I am not saying that freeze-all is a debate, but rather it is optimization of clinician and embryologists for proving their abilities to give a better pregnancy rates, where the main aim is of any organization, any clinic, is decreased time to get pregnancy interval with the cost effectiveness. Different ART centers have developed their own freezing strategy based on their personal experience and choice. This is an important drawback that limits to identify that which is the best timing. Still we are debating. Which is the best embryo selection? Still we are debating. Which is the best method? Still somebody is saying I am best. And which is the best endometrial preparation? There is no doubt about the natural HRT is the best endometrial selection for that. So now my last conclusion of freeze-all is that at the outset I will say yes, I accept, I am doing, but still at the outset I will say extraordinary claims require extraordinary evidence.
Thank you, Dr. Jayesh, for enlightening the audience with the freeze-out technique, which is not only having given very good results, very good implementation, avoiding all the complications like OHSS. On the top of it, there is a decreased low birth rate and it is very much convenient for both patients and for the doctor. I know it is going to be a future. Thank you, sir.
Here I request Dr. Jayesh Patel sir to hand over forward to Dr. Jayesh.
Now we welcome Dr. N. Gauri Devi to enlighten all of us with her lecture. She is the director of Gauri Hospitals. She is director of Rich IVF Group, runs a chain of IVF centers. She is president-elect Indian Fertility Society, Secretary General Indian Fertility Society, Executive AOGD Governing Council, Member Executive Board NACHI and PTDS, ex-Vice President NACHI, Chairperson Advocacy and Ethics Committee IFS, State Quality Assurance Committee, Government of NCT of Delhi, Member NTP Advisory Committee, Government of NCT of Delhi. She is a keen academician, has organized many conferences, has been a speaker in many national and international conferences. Welcome you, madam.
Good afternoon, everyone. At the onset, I would like to thank Dr. Rajesh Kamil and his team of SOGS members and Dr. Jayesh and Dr. Nivesh from IFS for giving me an opportunity to talk in this focused program on PCOS. Always, the focused conference give you more information and it is always interesting also. I shall be talking, I was given the task of talking on the PCOS guidelines which IFS has formed, and I was supposed to compare it with other guidelines. That will be too much. The time given to me will not be enough for me to do. So I'll just project some slides which will tell us what are the other societies' guidelines are. Actually, this is the two booklets. I asked their people to give us these booklets. Somehow they haven't brought it. We have produced two booklets. One is on the management of PCOS in India. The second is the management of infertility in PCOS patients from India. What we did was, it was under the presidency of Dr. Sonia Malik, who took great initiative that we tried to do this guidelines. We all know, according to the ethnicity, the percentage of PCO patients varies from place to place, and India, from different studies, is said to be 3.7 to 22%. And all these patients come to general practitioners, pediatricians, endocrinologists, dermatologists, so on and so forth. Now, when we looked at it, evidence was not lacking. If you look at SRM guidelines when they formed, they looked at 244 papers, and when we looked at Indian papers, we had about 147 references from different journals. So we conducted two meetings. One was on the north and east in Delhi, and the other was in Mumbai. There were about 30 committee members. We had all the people, gynecologists, endocrinologists, dermatologists, pediatricians, ultrasonographers, general practitioners, all were there in both the meetings. You can see some of the pictures of this is the Delhi meet, this is the Bombay meet. And how did we grade these evidences? Strength of recommendation, A means strongly recommended, B is suggested, C is unresolved. When I tell the guidelines, these will come on the side. That's why I'm telling you the gradations. And evidence level of scientific support was at least grade 1 means, evidence level 1 means at least one RCT or meta-analysis RCTs. And 2 means at least one non-randomized, non-controlled prospective epidemiological study. 3 means cross-sectional study or surveillance or trial study. 4th is existing guidelines or consensus expert opinion on extensive patient experience or review. Now, when the ASRM guidelines were formed, you all must be knowing there were they had three consensus meetings. Rotterdam in 2003 for the diagnosis, and then again in Thessaloniki, Greece for the infertility, and third was in Amsterdam for the metabolic whatever the metabolic side effects are in the later life. So that was the first time in 2003 a diagnostic criteria was for PCOS was established. Before that we were in the dark. Now, what about the phenotype classification of PCOS? We have a phenotype A, which has all the three. That is, as I told you before, ovulation and androgen excess and polycystic ovary. If any of the two of the three criteria are met with, you can diagnose the PCO. What about phenotype classification? You have all the three features, that is phenotype A. Only two of the features, accordingly, we have categorized into B, C, and D. What did we find in India? Indian studies, when we did, we found that the phenotype A was the maximum. As you can see there, it was 65% is phenotype A. Now, coming to the, if you see other criteria like NIH, Rotterdam, and PCO society, you can see that different people have different criteria. That is why the need for us to see our own guidelines, because phenotype differs in India compared to the other countries. Now, coming to other additional recommendation, in adults and adolescents, presence of acanthosis nigricans with or without obesity is one additional criteria. If you come to the last slide, in adolescents, presence of oligomenorrhea or amenorrhea beyond 2 years of menarche is the earliest of PCOS. We all know that when the girl is undergoing the adolescence, that is something similar to a PCO, because there is a lot of activity between the hypothalamo-pituitary axis, more of FSH, you find more of follicles, but in about 2.5 years time, the girl settles. Till that time, we cannot label the girl as a PCO. Now, coming to the risk assessment, I have put on the right side all the biochemical characteristics, and on the left side all the clinical symptoms. So, Indian guidelines, Indian women showing at least one biochemical characteristic in conjunction with one clinical symptom, we should further evaluate for PCOS. About the androgen excess, what we found was that total testosterone was more reliable as compared to free testosterone and free androgen index. And hirsutism, acne, alopecia were the symptoms of hyperandrogenism. And ovulatory dysfunction could be either way. It could be too frequent cycles or prolonged cycles. Sometimes there are normal cycles but still anovulatory. And polycystic ovary morphology, you all know that you have been discussing about it right from the morning. Now let us go to the importance of AMH levels. Dr. Nina talked about it. Follicular study with LH-FSH ratio, AMH, are also recommended only in very specific time. AMH levels reflect the number of growing follicles as a marker of ovarian reserve. Indian study, baseline serum AMH levels were twofold higher in PCO than in healthy infertile subjects, thereby suggesting it as a potential marker for recruiting non-growing follicles. And as you can see in the last, AMH level of 3.15, above that if you get, you should think of it. Now, I'll just categorize it into adolescents, adults, and infertility. Then we can move faster. In adolescents, as is 2 in every 5 adolescent Indian women suffer from PCOS. And the clinical features, as you can see, in adolescent girls. All the three should be there of the Rotterdam criteria in an adolescent girl for us to make a diagnosis of it. And what we found in Indian studies was that hyperandrogenism was the most common clinical presentation in adolescents, and many of us gynecologists do not get these patients because they land up with dermatologists. And what is the recommendations? The presence of oligomenorrhea or amenorrhea, as I told you, beyond 2 years, and Rotterdam criteria should be there, and the minimal diagnostic test that we should do is total testosterone, OGTT, 17-hydroxyprogesterone, serum thyroid and prolactin. We all know a minimal subclinical hypothyroidism or a slight hyperprolactinemia is found with these patients. Now, what is the management recommendation in an adolescent woman? Low dose contraceptive pill with anti-androgen progestins, which includes cyproterone acetate, drospirenone, desogestrel. You can choose any one of them which suits the patient. Cyproterone is said to have a little edge over the other two. And lifestyle modification as the first line. Metformin is the second line of therapy. And metformin should not be started if glucose tolerance is not established. That was the grade B evidence. Now, what is the pharmacological intervention in these patients? This I have already said. Between 12 to 16 years of age, please avoid giving continuous combined oral contraceptive pills, because if you give estrogen at that time, it can interfere with the interfere with the epiphyseal fusion, and the girl might have a stunted growth. And for the menstrual irregularity, always keep in mind when we are giving this combined oral contraceptive pill, this girl is a PCO, especially if she is obese, this is going to go on, and giving it continuously, thromboembolism should be kept in mind, and just our aim should be at least 4 to 5 cycles in a year, and that is what we should convince the parents. Daily strict physical activity of at least half an hour a day, and holistic yoga was found to be better than physical exercise in these women. And in overweight obese PCO, along with lifestyle modification, healthy balanced diet and restricted calories. What we found about yoga was that you can see that all those articles are by Indian authors. Work on the root cause of PCO, obesity, and stress is reduced, manages stress management, alleviates depression and anxiety, improves the glucose lipid the metabolism, reduces the AMH-LH ratio, and improves the menstrual frequency. Now, about myoinositol, there are a lot of observational studies we could get, but they are all very small studies. So as such, we have no evidence to say that myoinositol, acupuncture and all, they are not recommended because of the insufficient evidence. In adults, studies in India, as I told you before, it is between 3.7 to 22%. And here, the one extra feature is the infertility apart from the other three Rotterdam criteria. Now, what is the guideline recommendation for adults? As I told you, those who do not intend to conceive, you can put them on contraceptive pill with anti-androgen, especially if the woman is hirsute. But as we all know, there are some women who do not like to take continuous. You can even give progesterone withdrawal as far as they respond, as far as they respond to it. Now, direct hair removal methods are recommended along with the combined oral contraceptives, and no improvement with or intolerance to the COCs, you can switch over to spironolactone or finasteride for hirsutism. Now, what about the pharmacological interventions? As I told you before, you can do a progesterone withdrawal bleed, that is a grade A evidence. In adults who do not intend to conceive, it is recommended to use either drospirin or desogestrel as progesterone component. In adults with PCOS, metformin is not recommended as the first line of therapy for management of menstrual irregularity, nor is spironolactone recommended for menstrual irregularity. Now, for OGTT, one should always be looking out, screen it, and if you find that there is a lack of on the when we do the OGTT, thinking of the long-term effect, we should always take a diabetologist into into the consultation. Now, cardiovascular risk, to screen for cardiovascular by assessing risk factors, screen for impaired glucose tolerance and type 2 diabetes with the OGTT, specialist cardiovascular monitoring and care in all patients who have these risk factors. These patients, because of their obesity, inability to reduce the weight, it's very easy for us to say reduce, but because of that, they all have a tendency for depression and anxiety, which should be taken care of. And as I told you, yoga is said to help in it. And what about the pregnancy? This I'll talk later. Now, what about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, which you call as NASH? In the adult and adolescent women, especially those who are fat, it is better to do their lipid profile also, and the symptoms and complication of NAFL and NASH. And they should be carried out appropriate screening in those diagnosed with insulin resistance or metabolic syndrome. Now, cardiovascular, yes, the general cardiovascular recommendations like, reduce obesity, smoking, control hypertension, treat dyslipidemia, all these should be done. And screen cardiovascular disease in adult women with PCOS, with all this metabolic syndrome, the same thing. Now, coming to the guidelines for management of infertility, this was our second booklet where we dealt with infertility. This is an area solely addressed by us and general practitioners and infertility specialists, gynecologists, infertility specialists, and general practitioners. So, the guideline covers recommendations on counseling, optimal medical and surgical management with PCO in Indian women. You take for the diagnosis, I have already covered it in the first listing. Is counseling important, and what topics should be covered when the infertility patient comes? Yes, it's very preconceptional counseling. You should take care of their depression, because they must have been roaming around in many places coming to you because they are unable to conceive, and identify the risk factor, educate on the behavioral changes, chance of pregnancy, some multivitamin supplementation, and counsel them in detail about stepwise whether we are going to do clomiphene, then gonadotropin, and then you might land up in IVF. So all these should be told to them, and even the cost should be explained to them. Existing guidelines, just because I was asked to do, this is the RCOG guidelines, then there's Australian PCOS 2010 ESHRE guidelines. ESHRE recommends, but it's a little older, 2008 guidelines, identify risk factors for infertility, correct before treatment, recognize the presence of obesity and its distribution, recommend folate supplementation, advise on smoking cessation. Now, if you look at the pathophysiology of genetics, so many are there, but what we have found is that polystatin gene is strongest in the association with PCO. Now, what is the strategies for management of stress, management of PCO-related infertility? As you can see, preconceptual counseling, lifestyle modification, pharmacological intervention, surgery, and assisted reproductive technologies. With subfertility should be counseled for the need of identification and correction of long-term risk factors affecting fertility before you start the treatment. Healthcare professionals should provide pre-treatment counseling and weight reduction using lifestyle modification and behavioral changes. Emphasize the role of the husband. Husband should be told about the emotional support he should be giving to his subfertile woman. PCO women with subfertility should be counseled on the length of the procedure, side effects, success rate, as well as the cost of the treatment. Now, what is the complication that can have in pregnancy? You can have gestational diabetes mellitus, thromboembolism. Some of them can spontaneously abort, preterm labor, and wound infection. What in the lifestyle modification, I've been telling a lot. Here I'm going to specifically say, when you say a 100-kilo woman come to you for infertility, and if you say reduce weight, it's not easy that she will become a 65 kilo. So what we are trying to do is to put her on an exercise mode, put her on a reduced calorie mode, and then try her. Even if you get a 5 to 10% reduction in weight, it might be useful for her to conceive. That's what we are trying to do. And we should include calorie restriction, any diet, when we went through with maybe low carbohydrate, low fat, whatever diet it is, if they can reduce the weight, that is helpful. What about any surgery? Pharmacotherapy, when you give any Orlistat or any pharmacological agent to reduce weight. In polycystic ovarian patients with subfertility who are morbidly obese, that is BMI of more than 35, pharmacological method, you don't try to induce her, because where you have to use a lot of drugs because of their sheer weight. And the treatment with Orlistat is recommended under medical supervision. Bariatric surgery is recommended as a second-line treatment in morbidly obese, that is BMI of more than 40, subfertile polycystic ovarian patients, and with BMI of more than 50, that is suggested, bariatric is suggested as a first-line therapy for weight reduction. And I don't know, now in Delhi, we get quite a few patients who are ready for it. Even we get youngsters, because people marry late, they are PCO, they come at 25 or 28, they say that they have undergone bariatric because who can stop eating pastries? And this thing, it is very difficult. And in 1 year's time, they lose about 40 kilos. And if they are trying to conceive, we tell them to stabilize it for about one year before they try to conceive, because weight reduction is that drastic. Now, efficiency of Orlistat, it is found that it is as effective as metformin reducing weight and achieves similar and pharmacological treatment at greater weight reduction compared to just lifestyle intervention. Only thing is, when you are giving these drugs like Orlistat, we should tell them not to conceive when they are undergoing treatment. Once they reduce the weight, then they can take the treatment for infertility. RCOG says bariatric surgery may be an option for morbidly obese women with PCOS. Australian guidelines recommend bariatric surgery as a second-line therapy to improve fertility outcomes. Ashley states that bariatric surgery is recommended for weight reduction, but not for other consideration. Ovulation induction, I will just touch only the guidelines. Low-dose combined oral contraceptive pill treatment for at least 2 months, where the LH levels are high. You start the clomiphene with a 50 milligram dose per day, then gradually increase up to 150, and always tell them that it's better to go when they are taking the clomiphene. If they can undergo follicular monitoring, it is better, because even these patients sometimes can hyperstimulate. Clomiphene still remains a treatment of choice for induction of ovulation. I put the reference below, Eshrey as well as RCOG. Now, recommended guidelines, metformin is recommended where? In PCO with impaired glucose tolerance, in obese PCO, you can co-administer with clomiphene, as Dr. Nina said, the percentage of pregnancy goes up. In clomiphene resistant PCO, there also you can try metformin, and those who are at the risk of hyperstimulation, Dr. Nimesh said, you give it prior to 3 months, you give metformin, and then the chance of OHSS is said to be less. RCOG considers metformin in women who have glucose tolerance, which is resistant to lifestyle management, but recommends to follow Eshrey guidelines. So let's go to the Eshrey first. What does Eshrey guidelines say? no advantage of adding metformin to CC in women with PCO, and suggests restricted use of metformin in patients with glucose intolerance. Probably in India, where the GDM is so much higher, this doesn't stand good for us. Next is, of course, gonadotropin is the second line of treatment, and when it is indicated, we have to counsel the patient, tell them the chance of hyperstimulation, and always a low dosage step-up protocol has a better result than a step-down protocol, and always start from a very low dosage. If you are trying to do a monofollicular or 1 or 2 follicles, start with a very low chronic low step-up protocol, and that's how it goes. In anovulatory and subfertile polycystic ovarian syndrome patients with clomiphene resistance, you can take letrozole. Actually, when we were forming these guidelines, letrozole was a banned drug. That's why here we have only mentioned it, and we said this use will be considered off-label, but now they have come out with it. In cancer, fertility preservation, where you don't want a high level of estrogen, there we can give letrozole first and then do the random protocol or a regular protocol. Now, what is the indication for laparoscopic ovarian drilling? Patient with clomiphene resistance, patient with a persistent hypersecretion of LH, the need for laparoscopic assessment of their pelvis for some other reason, and poor access to healthcare facilities. You can do a laparoscopy ovarian drilling and the patient has gone. Spontaneous conception rate is said to be much when they cannot afford IVF or IUI. Now, this is the recommendation that what I said there, that is only written here. And now, what about ART? Associated with male factors of fertility or women with unsuccessful conception despite ovulation induction, one can go for intrauterine insemination. The third line of treatment is for IVF. Whom do we give IVF is suggested? It is the third line of treatment option in women with PCOS who fail to conceive. And an antagonist protocol is the preferred protocol compared to agonist, and always start with a lower dosage of 75 or 150 units and proceed, avoid OHSS. So, what about luteal support? Here, we have not able to reach a conclusion because there is so much of variation from different papers. Some, 800 milligram, 400 milligram, addition of dufeston, injectable daily and injectable weekly. That is where we have just put it as addition of luteal phase progesterone is recommended in subfertile polycystic ovarian syndrome women undergoing ovulation induction or assisted reproduction. Look at the, can you people see it? That is the last slide. Can you, I don't know if there are any answers. Can you see that slide properly? There is, if there is a presentation of patient with infertility, first you treat them with, if LH is high, you treat them with contraceptives, then you give clomiphene. If there is an ovulation and pregnancy, the work is done. There is no pregnancy and 6 cycles of ovulation with timed intercourse, go for IUI. And if there is pregnancy, fine. No pregnancy, go for IVF. On the other side, if there is 3 cycles, no ovulation, if BMI is more than 30, then treat with clomiphene and metformin. On the other side, if the ovulation occurs, then you follow the B pathway. Anovulation then means you will have to go for a laparoscopic ovarian drilling or go for gonadotropins. If with gonadotropin there is ovulation, follow pathway B. With anovulation, you go for letrozole. Letrozole also anovulation, go for IVF. And if there is ovulation, follow pathway B. With that, I thank you all for a patient hearing.
Thank you, ma'am, for a nice lecture. I request here Dr. Kamla Bhattacharya to hand over the momentum to ma'am. I request Dr. Dr.Jayesh ma'am to hand over the momentum. to Dr. Jayesh, sir. Request Dr. Alok Goel. Dr. Nilima. Here we also welcome Dr. Girish Patel. He is a fetal medicine expert at Beams Hospital, Ahmedabad. I request Dr. Darshan Vadekar. Please come in and welcome you to the floor. As we are now heading towards our another session of panel discussion, I would request your moderator Dr. Praful Dosi along with Dr. Rajesh to take a lead. Barely anyone in the room doesn't know Dr. Praful Dosi sir. He is a teacher of teachers. He looks as if he is 25, but well experienced for more than 25 years. Welcome, sir.
वही मैं कर आप आ जाओ ना मैडम दिस इज व्हाट you can do announcement
इसको लगा दो I have a request to make you all. We are having our annual conference of fertilization this time in Delhi. It is in Aerocity, Pullman Hotel, and we have got a faculty about 15 or 17 foreign faculty and about 275 or 300 Indian faculty. There are a lot of panel discussion, debates, all the latest in infertility as well as IVF. So I request all of you to come to Delhi and be our guests. Thank you.
माइनस करवाना ना बीजू बस
Good afternoon, ladies and gentlemen. From the morning, we are having a feast of knowledge on PCOS. When your receptors for knowledge in the brain are getting down-regulated with so much bombarding on one subject, and your receptors of ghrelin, which is supposed to be a hunger hormone, is getting stimulated, we are the last in the CME program. And this will be mostly a revision because everything is covered so exhaustively, especially with the guidelines. All topics have been completely covered in detail. So this will be a fast revision. I myself, Praful Doshi, with Dr. Tuli, will be moderating one of the largest panels in my career, the 10 experts and 2 moderators. So we will go, we'll take you through practical aspects, and it will be a revision. So I invite all the experts on the dais. I'll just speak the names. They have been introduced, and the others you know. Dr. Nina Malhotra, Dr. Mamta Dindayal, Dr. Nimish Shelat, Dr. Pawan Dheer, Dr. Vipul Kapadia, Dr. Prakash Bhatt is not visible, I suppose. Dr. Rupal Shah is not there also. Dr. Jayesh Patel, Dr. Mona Shroff, and Dr. Pankaj Chaklasia. So with 2 absentees, they did not allow me to break the record of largest panel. And we go quickly towards our panel discussion. I hope I'll just announce the names again and you raise your hand. I will not be introducing them, but so that you know who is who. Dr. Nina Malhotra, Dr. Mamta Dindayal, Dr. Nimish Shelat, Dr. Pawan Dheer, Dr. Vipul Kapadia, Dr. Jayesh Patel, Dr. Mona Shroff, and Dr. Pankaj Chaklasia. Now, we see a lot of PCO nowadays. Now, my question is whether incidence of PCO is rising or is it just more diagnosed? I direct this question to Dr. Jayesh Patel.
PCO is more or less a lifestyle disease also. So incidence is also rising as well as with better ultrasound machines we diagnose it more, and awareness among the clinician is also increasing. So diagnosis is also increasing. So both are increasing.
Thank you for the brief answer, and we'll be putting the answer slides for quick revision for the audience. So both things are working. There is increase because of lifestyle things, and also the definition is now more well established. When you take 3 criteria and only 2 are sufficient, obviously the more cases are picked up now. I request the panelists to be short and brief as he just did, so that we can finish in time.
The second question comes, how common it is and how many women may be having PCOS, maybe globally or India, you can tell. Anyone, sir. In fact, the time is short, so we don't point out any person.
so that they don't pick.
Okay, sir. Dr. Nimish Sharat, sir, please.
The range of there is just series of PCO, like polycystic ovarian syndrome, and not only just PCO. Polycystic ovarian syndrome is not as much as common as just plain PCO. It is the range varies from area to area, but because it's quite regionalized in some places. But the uniform incidence is right from 13%, and it can go as high as 33%.
The answer says that if we use strictly NIH criteria, it is 6 to 8%. For tender criteria, which actually include many other factors after that, 15 to 25%. And what Nimish like I said, it really varies a lot, maybe from 10 to 30% also.
We will take you through the life cycle of one girl called Miss Polly from polycystic ovary. So let us talk about her and walk through the journey of her life from beginning. As it is said that PCOS is a disease from womb to tomb. So the journey starts from the intrauterine life itself. It is said that PCOS is acquired in utero. Can you tell me how, Dr. Vipul Kapadia?
Babies, female babies, or mothers who are exposed to more antigens in the intrauterine life have a greater incidence of developing PCOS later in life.
Yes, and also anyone would like to add?
There are other genetic and epigenetic
Genetically,
factors
of course.
as well. And there's something called as a 50 hypothesis, where calorie restriction or intrauterine growth restriction leads to more insulin secretion by the fetus and ultimately the insulin resistance and PCOS.
Yes, so it is covered. The answer is there are genetic causes. There are small for date babies have higher chances of PCOS, and maternal androgen exposure is also incriminated for PCOS etiology.
Dr. Pankaj, next question for you. What is the genetic basis of PCOS and how does PCOS transmission behave genetically?
Nowadays, proven PCOS have a genetic factor. Any mother have a previous history, then that offspring also in a family history. If a woman have a PCOS, then sister is having also PCOS, chances are increasing. Because it is a genetically determined obesity is there. And genetically by so many genes are responsible for this PCOS DNA, and that is genetically determined, and also that is the main reason.
Says that family constraint is known and risk of PCOS is far higher, that is 40% if it is a sister and around 20% if mother is suffering from PCOS.
So as he rightly said, there are several genes incriminated, but not a single gene specifically has been found in all PCOS, but it behaves just like autosomal dominant gene. And there is no conclusive result about the genetic this thing, but it is almost proven that there is some kind of genetic basis. So the next question, now this is about the etiology, but now from the birth we straight take you to Miss Polly of 16 years. Now she is adolescent, and now she comes to you. Dr. Pawan, tell me the complaints, different complaints that she is likely to present with when she is 16 and she is PCOS.
Polly 16, she may come with mostly acne, irregular menstrual bleeding, excessive hair, male pattern, and parasitic. She will say that suddenly I am getting the weight. She may be already on fast food. These are the basic complaints she may have.
Infertility will not come here just to complete the different presentations, but at 16 years, she will present with either menstrual disorder or obesity or hirsutism and acne, which are the commonest presentations.
And the next question, Dr. Melissa, for you, which is the first investigation which you like to do for her?
Is it for 16-year-old or you want to ask the industry for any research?
No, we are talking about
that's 16 years. She comes to you. with some complaint of menstrual irregularity or whatever.
If I say, if the history is suggestive, I really don't need to investigate. It should give me history of clinical or hyperandrogenism, and there is a history of anovulation in the form of prolonged cycles. I don't think I really need anything to investigate because the Rotterdam criteria she fulfills 2 out of the 3. So it's clear, clinical. But yes, if she doesn't have the florid picture, then a person who has maybe 1 out of 3 and I want to anything wrong, then for her, I would like to do maybe an ultrasound. Which would be a little different because she's unmarried, she may be obese, but that's the only thing I offer rather than going for any biochemistry.
Yes, very right. If you have one of these symptoms, you would first of all like to see ultrasound picture, and Dr. Mamta Dindayal beautifully took that lecture of ultrasound. That's the first thing you would like to do because it's an important criteria considered in Rotterdam criteria. Now, what USG appearance is called PCO? Of course, you give the lecture, you can elaborate maximally, but you will add to somebody else. Yes?
In an adolescent misquality at 16 is of no value.
So I wanted you to add that later when somebody says that, but you already added that. But Dr. Mona, which USG appearance is called polycystic ovary? We are not talking about syndrome, just the appearance, USG appearance.
More than 12 follicles of between 2 to 9 mm on either side. Even any one ovary showing a polycystic appearance can be called as a PCO. And it need not always be arranged in the periphery to label it as PCO. Or the volume of the ovary if it is more than 10 centimeter cube.
Yes, so answered all 3 questions and sub-questions. Presence of 12 or more follicles, even if in one ovary, and optimal time is day 3 to day 5. Dr. Pawan, yes.
Stromal blood supply.
Sorry?
Stromal blood supply in this scan.
Yes, Dr. Mamta, we would agree to that, stromal blood supply.
Yeah, in contrast to what you're saying, which days they should do your ultrasound.
Yeah, optimal time. Yeah.
The optimal time is time your patient reports because the intracycle radiation is not there as far as antral follicle count is concerned. It's only if there is a cyst or corpus luteum that you don't measure in that cycle, or if she's on posticles, you don't measure irrespective of the day. So I think we have to be very clear on that. You can do an antral follicle count any time in the cycle. In the absence of corpus.
Yeah, it's only about the optimal time. When she has oligomenorrhea and not ovulating, any day is equally good. Yes?
We have been talking about criteria for a 16-year-old lady. I don't think that is very applicable because she's still growing. She has regular periods anyways. She may have a familial hyperthyroidism. And so, Rotterdam criteria is not a very, very good diagnostic criteria for a growing girl.
In fact, Rotterdam criteria have been criticized in many ways.
There are age-related changes in definition of PCOS and adolescence.
Yes, but right now we do not have other guidelines to diagnose or label a PCOS other than Rotterdam criteria. Although it has been criticized on many fronts, Rotterdam criteria, and even the number, as mentioned, has now been increased from 12 to 19, and there are papers which say that it should be increased even more for more specificity. To find in a young girl 12 follicles on both the sides is quite common. But as of now, we stick to Rotterdam criteria, and therefore this is the criteria defined by Rotterdam, that only one ovary is sufficient even if the other ovary is normal, as mentioned. And if many of these girls sometimes are on withdrawal bleed because of delayed this thing, then you would, and of course another limitation here in ultrasound in a very young girl is the abdominal ultrasound, which is much, gives much less information as compared to vaginal ultrasound. You would say anything on that?
If there is a need and she is overtly hyperandrogenic and she's concerned about her hyperandrogenemia and she's an adolescent, you can do a rectal ultrasound with permission.
Yes.
It gives you the same picture because just about a couple of months ago, There was a patient diagnosed as a case of polycystic adolescent, and she had a tumor of the ovary, an androgen tumor of the ovary. So if the patient is florid hyperandrogenic, maybe you will require to do a rectal ultrasound and make that diagnosis. And we should not otherwise. For a routine, no. Poly 60 years, leave her alone.
Right. So very rightly said. And with very smaller and smaller probes available, it may not be too uncomfortable to do with permission transvaginal ultrasound or transrectal at least.
Even adolescents, we may not need to give a diagnosis at that point of time. We can simply treat them symptomatically at that stage and maybe give the diagnosis or label them as a PCOS at a later stage.
We will talk about that counseling part, but there can be difference of opinion. So if there is a clear-cut labeling like hypoandrogenism and other things, you have to label them. If you just give treatment like withdrawal bleeding and don't tell them anything, they are likely to be lost to follow.
First 2 years after menarche, all the symptoms can be physiological. Physiological hyperandrogenism can be there. Delayed periods can be a normal part of the first 2-3 years of menarche. So sometimes we overdiagnose as well.
That's absolutely right. And as she said, there's a florid picture, a very old picture, then you would like to confirm and probably stamp that. Otherwise, there is no hurry to stamp her as PCOS.
Question for you. Assuming that she might be having PCOS and what has already been discussed that sonography may not be required in that case, what other investigation would you like to have?
Then keep it on, all the mics.
I would like to do blood reports, hormone testing, LH and FSH, and then serum testosterone level, and sex hormone binding globulin, also thyroid and prolactin level, and for obesity and hyperinsulinemia, fasting glucose is more important. For these are the main.
Can you also speak the importance of each investigation, like how it is going to help you by doing this investigation with each one line, whatever you answer.
Starting from first.
If testosterone is high, then it already indicates there is a hyperandrogenism. Excess is there. LH-FS ratio is called 2:1 ratio or more, then there is a higher chances of by genetically increased LH, by GNRH increased frequency there. Also is favored there is a tonically elevated LH. ESS, mostly hypothyroidism is associated with PCO, and prolactin, hyperprolactin is also associated. Fasting glucose with insulin ratio is also indicate insulin resistance. If ratio is less than 4.5, then it indicates there is a insulin resistance. And also, if advanced, then lipid profile may alter, increase the triglyceride level, serum cholesterol level, that associated with obesity and other risk factors. 17-hydroxyprogesterone level is also indicated. There is an enzyme defect. Enzyme defect will role for androgen excess. That also indicates there is hyperandrogenism.
I think Madam Doctor wanted to say.
I won't do any of those tests except fasting glucose. I think it's a waste to put money. I think she should invest it in her education.
Sorry, what did you say? We should?
She should invest that in her education, just get a blood sugar done for her. I mean, her oral glucose tolerance test, and I would not do anything else because it doesn't benefit anybody. And you cannot act on it. I always believe that you should do an investigation which is going to give you a lead in the case. None of the investigations are going to give you a lead.
Not thyroid, not thyroid, not TSH.
She would have other clinical features to suggest that. Maybe if you feel comfortable and you want to do something, maybe yes. But doesn't show signs
if she is obese, for example, you would not like to rule out hypothyroidism?
I still go by her clinical features, and doing a TSH is okay still. But doing an FSH, NH, testosterone, prolactin, so on and so forth, I would not.
There are certain investigations which require for follow-up.
What will you follow up? I'm sorry, but we're having a general discussion.
Like for example, if she has a high testosterone and if you've given her, say, combined contraceptive pills.
Then you will give her any which way if you feel that.
Yeah, but then she
why should you do a test for that?
then she should be convinced that her testosterone level is falling at the end of, say, 3 months or so.
You should be convinced, not the patient.
She should be convinced. And besides, if your testosterone level doesn't come down, then you may have to add a few anti-androgen drugs, like spironolactone or putamine or whatever.
I would not do that.
Yes, Dr. Mona, yes, wants to say something.
Any investigation should be aimed at 3 things. One is if there is a doubt in diagnosis. Secondly, if you want to rule out a differential diagnosis in case of doubt. And the third is to find out complications of the, and if possible, if you are able to treat it. So I would only do TSH, prolactin and 75 gram OGTT, 2 hour glucose. Testosterone and 17-hydroxyprogesterone would be reserved for only severe early onset.
The apparent cases you have hyperandrogenism.
A severe hyperandrogenism at an early onset and a rapidly progressing hyperandrogenism.
Yes,
only in that case we are.
It's getting interesting. Yes,
So the question is focused on that 16-year-old only, right?
Well, this is just to have a picture in the mind of audience. It could be little here and there. Suppose she is 18 years, then no, not adult. We are talking about unmarried young girl. She could be 18 years, for example. She is going to go through that anyway.
A lot has been discussed, and Mamta has talked about just a single investigation. On the other side, what Dr. Mona has said, there's a wide spectrum, and the answer itself, which should be an ideal answer, is speaking of all these various investigations. We have to strike a balance somewhere, and whichever modality you find it, they should be, these investigations are warranted. One should do it and choose the investigations carefully, and some limited investigation should be done. If they provide a lead, and if you need some more, then I think, as Dr. Mona said, testosterone and 17-hydroxyprogesterone can be reserved for later evaluation in this section.
Thank you. Yes, this is a list of investigations, and as Dr. Dindal said, the whole list or whole category of investigation need not be applied to any case, not only about PCOS, but any condition that we are treating. We always, nobody, for example, none of us who will put the whole panel for all PCOS. But then these are the things which will be required in certain cases. For example, there is florid hyperandrogenism. So then, as Dr. Vipul Kapadia said, that you will require this level to know whether whatever you are giving is working or not, and also to impress upon her the need for treatment. So we have to strike a balance. About this oral GTT, Dr. Mona, you said, now why should we check for insulin resistance at all? What is the requirement?
First thing is, can we? Yeah, I think why should we check? Of course, it's one issue because there's a long-term risk of developing diabetes. But I want to tell you, what is the test for insulin resistance? Can anybody in the house or in the pan-micropan system, which is the test for insulin resistance? I can answer. We don't have any test for insulin resistance. HOMA-IR, but how many times you do HOMA-IR? Again, HOMA-IR is again a research setting. So, and HOMA-IR itself has it. So, if I say the other tests are all survey, I think it's again a very, very big gray zone. HOMA-IR is one thing, many the check and the others. So, I think I would say that you have to again be need-based on this. Definitely, OGT would be one of the baseline schemes to do that. That's it.
Yeah, so as you rightly said, there is a risk of future diabetes, and that is why if you label a patient, you think that it needs to be done, then you should check for insulin resistance, because it is going to be a future disease in a large percentage of cases. Risk of impaired glucose tolerance and type 2 diabetes mellitus is increased in both obese as well as non-obese PCOS women or girls.
I would just add again, please don't get carried away by sending a patient fasting in insulin levels. It will be nowhere other than wasting the patient's money and of course your time. I know a lot of diabetologists who will be sitting, if there are some, would still say some value that you have to post-prandial insulin rather than fasting. But then again, just one elevation of postprandial insulin does not mean she is insulin resistant. Yes, clinical could be obesity, yes, a central obesity, yes, a waist ratio, and of course, if there is a hair syndrome or a cancer migraines, that would be more. Even if the patient doesn't have a florid digestion or a clinical judgment would again be handled in house conditions.
Well, if you.
And the next question for you again, Dr. Meena.
You answered it partially, but the same.
Which investigation you would like to do to diagnose insulin resistance?
If at all you want to diagnose, like you said, that is more or less useless and there is no special criteria. But then, which are the criteria given for diagnosing insulin resistance?
Only clinical. Among the three,
Using fasting and 2 hour blood sugar levels falling 75 gram glucose load is normal, less than 100 fasting and less than 140 in impaired will be if it is between 100 and 126, and for PP if it is between 140 and 199. Similarly for NIDDM, it is over 126 and over 200 respectively.
So we have a very expert panel and the answers are coming exactly what they say. The insulin levels are really not needed and oral GTT will suffice is all that is needed if you really want to do. But anyway, if you want to confirm, not to prolong this question, that because people go from here learning about insulin resistance and they keep doing insulin resistance tests without even being able to interpret it. So it's unnecessary waste of money without ever knowing what are the levels that you really require to interpret. So insulin resistance has been defined as fasting glucose by insulin ratio less than 4.5 or fasting insulin more than 24 or post OGTT 1 hour insulin more than 150. This is just for theory's sake.
Tell me a clinical sign suggesting insulin resistance, said Dr. Jayesh. Very clearly told, the insulin resistance very commonly that is clinically said is acanthosis nigrans, which come over the skin because of the insulin which doesn't get used and gets into the skin and gives this type of shading appearance to the skin.
And if this girl only is the same, I will advise her to take therapy and wait every month and change her DP so that we can catch her early.
Yes, acanthosis nigricans is present in as many as 20% of obese girls, and this kind of skin tags that you see on the slide are also in 10% of cases. So this is a clinical sign which can suggest you the presence of insulin resistance. Now, this girl has delayed period up to 4 to 5 months as an only symptom, nothing else. Would you treat it? Why? If at all, yes. And how? Dr. Nimish.
Well, the period has to be delayed for almost such a long period of time. It has to be treated, but you do not mention the age of this patient. Appears to be around 20, maybe. One could definitely treat it. And
she is body getting less, looking like 20.
It doesn't matter, say anywhere between 16 to, even if she's 16, for example, but she's getting periods every 4, 5, 6 months or even more. Would you like to treat her? You will just accept her that this can happen in the beginning?
Because this is associated with gross obesity, the PCO in the picture, it has to be treated. If otherwise, normally, because we know that constitutionally she can have a delay.
No, this is just any random picture. She has only one symptom, delayed periods. Would you treat it still?
I would like to treat, because looking at the whole picture of the patient in the
Dr. Mamta showed beautiful pictures about it that cannot be forgotten. And the hysteroscopy in such women who have been not menstruating for months together. So it needs treatment because of chronic anovulation, which leads to endometrial hyperplasia and leads to high risk of endometrial carcinoma if not monitored. In addition, when they bleed, after many months of amenorrhea, they keep bleeding and severe anemia can occur, DUB can occur. And how will you treat? That was the another Dr. Jayesh. He said you would like to treat.
Yes, sir, because of PCO is a hyperandrogenic as well as hyperestrogenic condition, sir. We have to treat the menstrual irregularity. And
you said hypoestrogenic, sorry, hypoandrogenic as well as hyper
as well as hyperestrogenic both. So hyperestrogenic condition will lead to endometrial hyperplasia and carcinoma. So better we treat it, and regular shading should be allowed. The molecules which we use are combined OCPs, especially with prosperinol.
Anybody has any other? Dr. Vipul Kapadia?
Excellent. But what sort of approach is it?
So he said he preferably prefers drospirenol.
Yes, I think that's a very good thing because that will really take care of her androgenesis. Also, that will help her reduce her weight because of spironolactone.
Dr. Nina, you have any other opinion about treating these girls?
I think even because she has irregular erratic bleeding, she continues to bleed longer, progesterone is also one option. The idea is that they should have at least 5 to 6 bleeds per year. That's
So yes, that's the answer. Yeah, apart from combined OC pills, they may not like to take OC pills, and also the question is how long. So intermittent progesterone is another very good option, and this is how it can be given. We generally try to give try to choose the progesterone which are not androgenic, and therefore medroxyprogesterone acetate or micronized progesterone can be used orally, as although we use vaginally for luteal support and all. But here it can be used for 7 to 10 days, either each month or at least every 2 to 3 months.
Regarding hirsutism, supposing same patient having a different picture, she has poly has come, but the different picture having presented with hirsutism, how would you treat, Dr. E?
Here I will definitely use cyclophosphamide acetate. I will consult with the dermatologist also, and I will ask her to follow the weight reduction, 500 calories reduction, and
Dr. Nina is keen to add.
I think that there's a lot of give them anti-androgenic process, which is so like the first is not on that,
What type of dermatological treatment? Any ideas?
laser treatment would be best for us.
If she's having a good finance condition.
But then counseling is very important. That's most important because
We end up with depression when we have
that's very important. It's not a permanent solution. And of course, we have Vanika now, the which is available now. So we can try for that.
So very rightly said, this thing, very severe hirsutism is better left to specialists like dermatologists. But combined OC pills, any kind, especially the androgen, the pills which contain anti-androgens are more effective, but any pills are almost equally effective. But you can also add to the patients who are resistant to it, anti-androgens like spironolactone or finasteride. But please remember that the full clinical effect may take up to 6 months because it does not remove the hair which are already growing. The hair cycle, the new hair cycle is reduced, and it may take up to 3 to 6 months for any treatment to act.
Any cosmetic treatment being given is always temporary, may not last very long. Even laser, that has to be repeated every, say, 5 or 6 months. So ultimately, OC has to be given for
It's just a slide for the benefit of audience. Local cream, eflornithine, also applied along with other, this thing helps. available in different names like Hinder, for example.
The cream has to be applied and properly, thoroughly over that on the part and around it also. And anything else, if to be applied, to be kept for at least for 5 minutes, and then only something else can be put over it.
And then cosmetic treatment like waxing, shaving, which are not very satisfactory, but they are cheap and handy. And then laser therapy, which requires repeated sitting and very costly. Now, if hirsutism is of sudden onset, how would you manage, Dr. Vipulbhai?
Think of other causes of hirsutism apart from polycystic like acne causes.
Absolutely
like,
right.
Ovarian tumors, the androgenic ovarian tumors. So you have to then do proper ultrasound. You have to also do ultrasound of the abdominals. You have to do selective alpha hydroxyprogesterone levels, and you have to do certain cortisol depression tests.
Thank you. So in short, you should think about other causes and then enter into investigation. Just don't label it as PCO. If it's of sudden onset, you have to think of adrenal tumors, Cushing syndrome, and so on.
Dr. Mohan, is there any indication for ovarian drilling?
In this young patient?
Young patient.
No.
If she does not respond to your OC pills and other treatment, because ovarian drilling is expected to reduce hyperandrogenism.
No, never for a unmarried woman.
Yes. Drilling never, not at all recommended except in infertility problems.
Complaints of acne, we are taking to another symptom, and we'll be, of course, we will not take you to the whole journey of her because it's womb to tomb, but we will also go to tomb if we consider all the things that is going to happen to her, and it has been exhaustively covered. We will consider certain symptoms because practically, instead of just referring to primarily, you are the primary person whom patient comes to. So certain mild cases of all the symptoms, hirsutism, acne, other things, you can always treat. So now she complains of acne. Pankaj, would you advise topical treatment or some systemic treatment?
I will advise about systemic treatment. Definitely you have to combine oral pills, and for topical treatment, I would advise to skin consultant opinion is necessary.
It is very mild type, then also some medical treatment required.
What?
Very mild type, then also you need medical treatment.
Yes, very
systemic.
Systemic oral contraceptive definitely help to reduce the androgen excess. And then the topical treatment also required for this patient also.
Yes, Nimish.
I think if it's a very mild thing, we should reassure the patient and definitely follow up if you find it's increasing. But if it doesn't increase, sometimes what happens if we just unnecessarily treat with a very mild sick, later on the patient will think that she's very sick and she can get depressed. It's better to give them a lot of reassurance and confidence because this involves a lot of personal appearance issues in these patients. So if it is very mild as you have asked, we may just wait and watch.
Reassurance is very much important in that. That way it is dependent on.
What is mind?
If she has come to with that presentation, that means
more than 10 pimples over the face, she will really be hurt.
Yeah, of course.
Yes, Dr. Mamta wants to say.
I think even one pimple on the face can make a difference if she's sensitive.
Yes,
Women
this is what I wanted.
Men are different and women are different. You have to see patients are even more different. Especially if she has a troublesome mother, one pimple is enough for her to come to.
Yes, and if she has presented with this complaint, it means it matters to her the most. So these are the three grades. Inflammatory, you can just apply topical. Infected, when they are pustules, you can add antibiotics to it. And when it's very severe, then you can give OC pills plus topical and oral retinoids also. So in severe acne, oral antibiotics like doxycycline, minocycline, azithromycin, isotretinoin, and low-dose OC pills. All this combination works beautifully.
Which pill do you prefer?
Now the question comes this. You have already answered some of it. Which pill in acne and hirsutism?
Dr. Mona?
Other than the first generation, if it is mild, either of the pills would be good enough. Desogestrel pill, gestodine, cyproterone or drospirenone, all are equally effective. But if it is severe, I would prefer a cyproterone pill. And for long-term metabolic safety, a drospirenone pill is better.
Drospirenone does not offer any advantage, and there are some papers that it has thromboembolic risk is more. So, cyproterone acetate, yes, and otherwise, as you said, second generation. Why not first generation?
Because they have androgenic.
Absolutely, second generation desogestrel and other things are much less androgenic, and androgen is the main problem. So, second generation or third generation OC pills can be given. Long. Now that is the main question. We all give pills to many of these patients at 19 years or 18 years to regularize their cycles or acne or hirsutism. And most of these patients also get lost because we do not advise completely. And gynecologists, I think, are all confused about the duration of the treatment. How long? Dr. Nina, how long would you like to give OC pills if at all you start for any of these reasons?
Actually, I don't know how long, because there are times when the patient is on OC, she does the once to stop and she comes back with symptoms. So at the most, I think it's important to know what is her compliance, how does her mother take it, how does her family take it. I've had patients who are even given up to 18 months to 2 years, because as soon as I stop, her amenorrhea appears. But by and large, I think, I don't know, there is no guideline to guide me, but up to 1 year if there are symptoms.
Dr. Denda, I would like to give some practical tips on this. How long? Most people have this, there is no, yes. How long would you give OC pills to young girls?
I usually give it for a year, because that is when the changes on the skin in terms of acne and hirsutism come. I explain to them very clearly that she has to be compliant for 1 year. At the end of it, I stop for 1 or 2 months, and during that time, if at all I have to stop and the patient is becoming conscious of it, I use the progesterone for withdrawal. If she's having regular cycles, I will go back to OC pills. You can give OC pills as long as 5 years. As a matter of fact, it actually reduces complications later on, so what we say. I will use it for a year.
Okay, Doctor.
At the end of the year, you would stop for 2 or 3 cycles, but in that period,
I use
progesterone, and
I don't get, I want to have PCOS in years.
Yes, doctor. But it's slightly easier when you are dealing with an obese adolescent with PCOS, because then she is asked to reduce her weight, and if she reduces her weight, let's say by 4 to 7 kilos, then you can stop even earlier and switch over to natural micronized progesterone, and then gradually stop.
How many people advise weight reduction actually lose weight?
It's difficult, but it's not impossible. It's difficult, but it's not impossible.
I'll ask a question to the panelists in the house. How many people have given metformin to these girls, and when you have really the law?
So adolescent metformin?
Yes, metformin.
Yes.
Adolescent.
I have used it only in very obese girls who are in fact glucose tolerant, and it's not for regular.
Yes, Doctor.
When we are giving OCPs for a long duration, because these people often on they end up with OCPs. So we need to consider the long-term effects also. 3 things which we need to consider. One is the metabolic effects, like on the glucose intolerance of OCPs.
Like what?
Second, on the glucose intolerance, because OCPs may worsen the glucose intolerance. So monitoring of that is needed. Secondly, the thromboembolism, which we already discussed. And the third thing is long-term OCPs in PCOS are known to increase the inflammatory markers. So it is suggested that you should use some other drug or some other molecule, which we are still waiting for that ideal molecule, which will balance both the things, like the inflammatory markers as well as the symptoms and regularization of the treatment. So there was a suggestion of adding statins as well, or metformin with that advantage over for the inflammation part. So long-term metabolic effects may worsen with OCPs.
Well, there are a couple of papers that have even come in region, and there are some trials going on and looking at not just OCPs, there are randomized trials which have concluded that metformin is better because in some of these girls, they not only help them take care of their symptoms as well as the hormone profile, but they also help in weight loss, particularly obese. And also there is some big studies which are going on with myostatin because it's got anti-inflammatory effects. So there have been some Indian data which has even been published from Odisha. That's Dr. Surat has published some work. So that's what I want to ask. Is anybody in the house or in the panelists, has used metformin? Only in the movies.
Well, when metformin was on its peak popularity, I think everybody has used it without knowing how long. They just advise and then leave the girl at that to not to follow up. 1 month to just keep taking it, but then without knowing when to stop it. So when it was perceived that in metformin we have found all there was a time it was on its peak that we have found all the answers of PCO in metformin. And that big popularity, I think everybody has used it without actually knowing how long should it be used and what are the long-term benefits or otherwise of metformin. But again, the same thing about OC pills. We ourselves are afraid of giving it for a longer time without having a evidence-based proof. The modern pills do not lead to, on the contrary, in these girls, it will lead to better tolerance instead of proving or creating or causing intolerance. And there are millions of women in the world who are taking OC pills for years together for other things, up to 5 years, as Dr. Linda said, up to 5 years. There have been some report that after 5 years there may be a slight increase in the breast cancer. That was one report. But up to 5 years, they are practically without side effects. And in these patients, the cost-benefit ratio may be much more because it suppresses all the normal hormones. But when we are afraid of giving for more than 1 year, I don't think a patient is going to take for more than 2-3 months. So she'll come again, back and back.
I recall one case where I recommended the drug for 6 to 9 months. But one day she read on internet that it is a contraceptive pill also. So she told me I am continuing it for 6 more months because I am sexually active.
So to all the panelists, what are the strong points that we have for not continuing the OC pills for longer time in patients who are symptomatic with hirsutism, acne and obesity and irregularities? So standard picture, group A. What is our reasoning for not continuing it for more than 6 months or 1 year?
Only the one guaranteed reason that you are continuously suppressing the allergen access to those.
But it is doing good to this patient.
So you may give a chance of regaining that excess function by stopping it for a couple of months after a year of use.
But we are not starting at menarche. This patient has been off and on going into amenorrhea. She is coming to you after 4 years of menarche or 6 years of menarche. So there's no question of suppressing. If the HPO axis has to get settled, it would get settled.
And the only other thing is that we are talking about this body at 16, but say if you're starting at your 14, you may have a slight chance of early infusion.
Yeah, if it was early, yes. Estrogen 12 or 13, nobody starts, of course. Yes, ma'am.
For me, it is from mothers and the families concerned. Why oral pills? That's the only thing. Otherwise, medically, I think it's
yeah, Mike, please. Go ahead.
The Institute one-day conference and Albert Lesher came from New York. They had papers which showed long-term OC causes loss of ovarian reserve, which is not recoverable. So he was telling young girls, don't give continuously. He presented a proper paper on it. So long term, maybe we will have to check out on it. And after he said that, I started looking at these young girls who come because endocrinologists persistently put them on that. And actually there was one girl who had lost her reserve. I don't know whether it's because of that or indirectly because her mother was still menstruating at the age of 45. But this young girl, that reserve was 0.1.
But
so maybe long term, when they take it for 2 years, 3 years, we will have to.
As of now, madam, we don't have any logical explanation as to why she should lose her reserve faster with OC pills, because what OC pill does is just suppress the hormone, but it doesn't lead to any. But this one paper yet to be proved, I suppose. For all these years, OC pill has been one drug. Out of all pharmacology, the one drug which has been used maximally all over the world is OC pills for different reasons. So I think it is most tested, and that is why the list of side effects keeps growing. If anybody reads that on Google, nobody will take it for a single day. But you have to take it in its perspective. Anyway, I think it's about time, and there are many things to discuss, but I suppose it has been 1 hour nearly, or yes.
So can I ask 2 questions to the panel, because it's a PCO symposium. Already discussed, but we have to take some carrying on message. What is the opinion regarding the ovarian green? Ovarian green, laparoscopic ovarian green.
For infertility, you mean?
Infertility, yes. Now, what is your opinion at present? I will just ask Dr. Mamta Dindaya, Dr. Shaila, and Dr. Neena. What you say about
as far as ovarian bleeding is concerned, I restrict it only to those patients who have had a history of OHSS in the previous cycle, and I want to do it because her PMH levels are very high and she's resistant to any oral medication, and she cannot afford coherent. That's the only highlights. Not all.
Appreciate the large size ovaries, which you have tried using other endocrinological methods, giving them various hormonal treatments. But if they do not respond, and if it's a question of infertility, then in that case, breeding still has a place, and this breeding is most importantly, you get various suggestions that it should be only 4 holes. But there are various papers all over the world now which have actually devised and found out that it depends on the ovarian volume. If the volume is larger than 4 holes at the rate of 60 to 80 watts of electrocurrent, it would not be sufficient, because it will not help the reduction of the stroma and thereby bring down the androgen levels when we do drilling. So it's best to, there is a consensus developing that the ovarian volume, depending on the ovarian volume, you may require a larger drilling in these cases, but one has to be very choosy in selecting these patients. But if it should be always a second choice. If you can overcome without drilling, it is still the best, because when we drill, we are still reducing the ovarian reserve.
All the families are. My ideal case will be a patient with ovarian volume more than 10 LH more than 10, not responding to clomifene or any oral drugs, and simultaneously I have to do septum and tube testing in a single setting where I do therapeutic laparoscopy.
I will try to answer this question, Jayesh. I have found all these years there are 2 clear schools: those who are practicing ART and those who are not practicing ART. Those who are practicing ART are extremely afraid of ovarian drilling, and those who are not practicing ART are equally dogmatic about it being very useful. But I think, like similarity, I will give that like a forceps in obstetrics, where control was not possible, although it was a very useful drug. Procedure. The forceps has totally been out, and sooner or later, ovarian drilling has to be out, because there is no control about that 40 watts and 4 seconds and other things. They're very easy to do access.
Yes, there is a beautiful saying that PCOS is a medical disorder and has to be treated medically.
I would just put it here for those who are non-ART. If you're doing a septum or you're doing a routine laparoscopy, please don't be tempted to prick the ovaries. Please don't touch them. Because she's not even if she's treated or she's tried, because I read papers, she's not even being given clomifene, so I don't even know whether she's clomifene resistant. And the butts have been given, like cigarette butts, and she's coming with the AMH which is 1 or 1.2. I think where do we stand? I think that's something we should go. If In the present day, of course, non-ERT is not his patient. Today she may not be coming to me, she go, I think let's keep it restricted. Maybe a lean PCOS who has a high LH is where I know that she will give me trouble, and of course, it's not known that in the outside, she had a previous history and she's prone to OHSS has got one children.
So that means you are going to bring.
No, in fact, I might as well put a laparoscope only once I know. I would not jump. I don't do any laparoscopy without a baseline scan. I should know what I'm doing. I Google to reach your hotel. I think I'm going to do my road mapping first, rather than reach the, start my car and start finding the way. That's the way I do. So I would not do something that I scope here and then I do it. So I don't do that. I always do a baseline scan to all my infertility patients and a day 2 scan to at least know what they are, because there are many times when you get a surprise hydrosalpinx which has not been known by history, and that time I don't clip hydrosalpinx for an anesthetized patient. So my take is very different. I would always, do things complete before I.
Is there any EMH criteria?
I don't think there is an EMH criteria, but there's, we don't know that these exceptionally high images may actually benefit also by drilling, because who knows, out of 100, there may be one results with premature ovarian failure. I think we are like doctors, some professionals who do 100 goods, you will never be praised. You do one bad, you will be criticized by your own colleagues. So I think that's one thing which you have to take. So if you get one premature ovarian failure out of the 100 drillings, I'm sure you're going to be defamed more than anything.
So before IUI, how many is interested in drilling? Before IUI, how many is interested in drilling? There are people are saying, or most of the people practicing before IUI, they don't have a drill.
But why should you drill? Should she undergo IUI?
So that is what I am saying, that the polycystic ovary to where IVF.
Even IVF,
I want to come to the carry-on message. That means the carry-on message by the panel is not to read anywhere. That's it. That's what I say.
When you're doing an overwhelm, you're actually needing your drilling. So why should you do that? That's also if you really have the lever of a drill. Because many times you have a patient done IVF, she doesn't have a pregnancy, and 2 cycles later she comes with a pregnancy spontaneously.
Yes.
So that's that we have about. But that doesn't give us reason to drill every ovary.
So not to drill ovary in any PCOS patients anywhere. That is the carry-on message. I think so. But
no, there is a silence, because it's a blanket statement, carry-on statement cannot be given by panelists. You should not never drill, I suppose. No.
If she had a previous history of hyperstimulation, I would do.
But if she's 3 trained IUI centers, why should you drill? Give us the reason.
Depends on what you're drilling, the pocket or the ovaries.
Madam Neena, question for you. You said that many times patients come with you for work pickup and you do drilling over there, a type of drilling only. And after 2 cycles, patient conceives spontaneously. Does that indirectly means that drilling helps?
Yes, it is, but then I'm not using it with a thermal injury.
So that is what we want to know, that whether we should not use it or we should risk it selective cases.
Do I have a control on the ward? I don't think so. Has anybody, whatever studies have been done, what is your check meter? Because I'm drilling with a needle, I don't have an energy source. So my worry of drilling when you do laparoscopy is not of the drill, but it is about the thermal injury that you're causing. We say, as Dr. Jayesh said, 40 watts, 4 settings, this setting. Are you really knowing that the point which you're going is actually 40
That
watts?
means in any way we should have full control over it, having very minimal drilling over to be done. What commonly said that 2 drill and 2 seconds like that, or 4 drills and 4 seconds, something like that. It should not be too much of drilling over there.
But what about drilling given away?
Patient and all doctors want to get a result. Means whatever means they get, ultimately should get the result.
Many a time our patients come back pregnant and we tell them nothing can happen. And that's the time you want to go under the table. Yeah, many times. And mourn after IVF. Haven't you seen that? You really don't know what to do and you're like, you just want to disappear, but they bring the baby in surety and say, I did a better job, so I congratulate the husband.
Especially when they are called low images. especially when there are ones who come with low NHs. Spontaneous pregnancy with a level 0.3.
There are many ways you can get pregnant.
I think one can do IFS before and after drilling also.
Yeah, there are.
What is this?
There is a beautiful paper from the institute which they actually showed that there was a decline in NH levels. That's what prompted. But
You should be careful about your legal consultant if you do that.
One thing is you cannot just continue indefinitely and just do nothing and just avoid drilling all the time. A time will come when despite doing everything, you have still that PCO sitting in that patient, and 6 months, 7 months, 8 months, if you just be conservative, if there is no result, as Dr. Tully pointed out, the patient wants a result ultimately. And if it is a proven fact that conservative drilling has produced results in the past, a lot of centers used to do it, so we cannot immediately throw it out of the window. Maybe more and more modalities will be discovered because so that we can totally weed out drilling. Because right now we don't have anything better than that. So right now, and there is nothing to worry about the wattage of the current. If you use a microprocessor controlled cautery, which are and various devices which are now coming, they have a very high accuracy that it will not do greater damage. Laser drilling also will not do much damage. So controlled application is necessary.
So, I think this drilling is going to stay for some time because it's history. The first PCOS were treated by surgery, by Steen and Leventhal. So, it is going to stay at least for some time, unless, but like forceps, as I said, the future is probably already charted, that it is going to go out of this thing. So thank you very much. We have many things left about it, but the whole thing has been covered from morning now on. So let us thank you very much, audience, for being so patient in spite of 2:20. Thank you very much, and thank you, dear panelists. You are very enlightening. Thank you very much.
I request Dr. Jayesh to consider Dr.
All panelists, please stay here for a photograph.
Also, 35. They have a quiz over it.
Sir, stay here to.
All panelists, please.
Yes, I mean, sir, please, roll this computer power in, sir. Sir, please hand over to all panelists.
All panelists are aging patient. One group.
Really energetic.
Good audience, right?
Dr. Savior and Dr. Shweta, please come for the presentation by Dr. Mukta.
Thank you. It was a lot of repetition, so I was not ready to take an again.
Dr. Pankaj here. Another Pankaj, Dr. Pankaj Chaklas here.
Namaste.
Dr. Doshi sir. like Dr. Prabhu, like, please, program. All our SOGS committee members are please requested to come over here for a photograph.
अभी फोन करके लाइव ये सब यूट्यूब पे जाएगा ना